February 27th meeting. Does anyone have any changes they would like to make to the minutes? If not, is there a motion to approve the minutes? Any second? Okay, you should probably turn on your microphone. Okay, Lauren's abstaining because she wasn't here last time. So all in favor of approving the minutes, say aye. Any in opposition? And one abstention? Okay, so the minutes are approved. So we have I guess about 4 issues that we want to go through in the program today. And we only have an hour and a half, so we're going to try and keep us moving along. Let me just ask David if he wants to, David Summersby wants to say anything by introduction to the meeting.
Sure. Yeah, just a few quick words. We do have a full agenda for this meeting and the meeting after, but do want to first acknowledge our HBC Summer Fellows who have joined us for this meeting and started on Monday. Our fellowship program is one of the things I think Colleen and I are most proud of at the HBC over the years. This is a full-time fellowship program. Students from across the country who are working for us on different projects, all graduate students, medical students, law students. So summer has arrived, our fellows are here. We'll have a few more words to say at the board meeting in July, but we want to acknowledge their presence here. And I think it's kind of a well-timed meeting because I think for those of you in the audience and the public, if you're able to stay for the full 3.5 hours of meetings that we have planned today, you'll really get a sense of the breadth and depth of different policy issues that the Health Policy Commission is working on, from market oversight to pharmaceutical drugs to social determinants of health, and a lot of things in between. So our first agenda item today is an update on our registration of provider organizations program. And this was something that we had on the agenda at the last meeting and ran out of time, so wanted to begin there. And just by way of introduction, just want to say that this program really is a unique program. There is not any other state that collects this type of information. And I just want to reflect that I had the honor of being at Academy Health, which is a research conference over the last 2 days, health services research conference, and every single researcher would is so jealous of this information that we've been able to collect and its power and ability to be able to understand the healthcare market. And so I think we've done a very judicious job of building this program over time, balancing, as you'll hear, the administrative burden, but really just a reflection of Massachusetts leading the way again. So I've got a lot more to cover, so I think it's probably best if we just jump right in. So I think we'll turn it over to Liz Reedy and Tom Hodge on our RPO team to walk through just an overview and an update of the registration provider organization program. It's been a while, so we're going to kind of start at the beginning of what this is again, and then some updates and some highlights over the last 5 years running the program.
Thank you, David, and good morning, everyone. So as David said, we're here today to provide updates on our 2019 RPO filing and to offer some reflections on the program to date. So as you know, RPO is our first in the nation data collection program through which the Commonwealth's largest health systems annually submit information about their structure, relationships, and operations, and we make that information available to the public. This is a big week for us. We are releasing Provider Organizations 2018 data on our website, in fact today. And on Monday, we opened the online submission platform for provider organizations to submit their 2019 filings to us. The 2019 registration cycle also marks an important milestone in the program's history. It's our 5th data collection cycle, which is hard to believe that it's already here. A lot has changed since the beginning of the program when we were just starting to wrap our heads around this section of Chapter 224 and create a program from scratch. Our goals were initially quite modest. They were to identify the largest health systems in Massachusetts and to form a baseline understanding of who they are, how they operate, and how they're related to each other, and to provide that information to the public. And over the last 5 years, teams at the HPC have used RPO data in conjunction with other data sets such as the All-Payer Claims Database, confidential information that we've received from custom market impact reviews, to produce some pretty sophisticated analyses about provider organization performance variation, about the impacts of mergers and acquisitions, just to name a few. And the results of these projects are very complex and compelling, and it can be easy to forget how little we really knew about the provider market structure 5 years ago when we first set out, and how critical the RPO baseline data have been to understanding and producing those results. To perform these types of analyses about health system functioning, you need to be able to answer some basic questions like which hospitals does a certain system own, which providers do they negotiate payer contracts on behalf of, how is the system governed, and how much influence does it have over its participating members, does the system own urgent care centers, where are they located, how many physicians are part of a network, how has the system performed financially over the past 3 years. Just some examples, and they're all fairly basic, but it's crucial information that RPO collects in a standardized format every year that allows teams at the HPC and teams externally, as you can see from the slide, to be able to do their work. So on the 5th anniversary of the program, we wanted to take the opportunity to pause and reflect on how the program has been implemented, identify some things that we've done well and want to continue doing, and consider areas for improvement as well. And to do this, we'll use the framework of our guiding principles. We adopted the statements on this slide back in 2013, and we start from these principles whenever we design new reporting requirements. The first is a commitment to administrative simplification, and the following slides detail a few examples of how we've tried to create a streamlined experience for provider organizations. One of the first decisions that we made was to build an online submission platform, which is the website that providers use to submit their filings to us. It's helpful not to receive paper filings or filings via email attachments, but it's also very important because a lot of the information that we collect doesn't change year over year. So when a provider reports to us which facilities they own or who their clinical partners are, they enter the information into the online submission platform, and the information gets saved in that year's filing. And when it's time to begin the next year's registration cycle, what we do is we take a full copy of the previous year's data set and make that information available to provider organizations so that they just have to review and make any updates to the information rather than re-entering it year over year. We're also committed to providing a high level of support and technical assistance to provider organizations. There are many opportunities and resources to provide information and answer questions, including through training sessions, one-on-one meetings, ad hoc phone calls and emails, pre-filing checklists where we communicate to provider organizations what information we expect they'll include in their filing, and generally just helping to update information in the platform and to troubleshoot any issues they may be having. We also regularly ask for feedback from registrants. For instance, asking questions about the resources we provide, about their experience updating information in the online submission platform, as well as asking about how they themselves are using RPO data. And this slide includes some examples of the feedback we received from a survey that we conducted in the spring. We then use the information to improve how we're asking for certain data, what resources we're putting out, and in what formats we're making data publicly available. The second of our guiding principles is to phase in reporting requirements over time. This slide here shows the areas for data collection in both the HPC's and CHIA's statutes. It's a very expansive statutory charge, as you can see, but we have not collected everything yet, and the following slides provide more of a breakdown of how we've phased in the reporting requirements over time. In the first 2 years of the program, we split the reporting requirements up to give provider organizations significant time to build up to a full filing. They were learning new terms and definitions and applying them to their systems for the first time, gathering information from different departments within their organizations. But we do think initial registration required the most effort on provider organizations' ends, since the information submitted often won't change much year over year, as I mentioned before, and since provider organizations can just review previously submitted information, make updates, rather than re-reporting everything each year. And we also try to add new requirements in small batches rather than all at once. For instance, we added financial statements files in 2017, and no new categories of information in 2018. And we still have not hit all the categories in the statute as we tried to balance the value of reporting the information with the burden on organizations, which is something you'll hear a little bit more about. With that, I'm going to turn it over to Tom, who's going to go through the remaining of our principles.
Great. So next we want to talk about our goal to avoid duplicative data requests. There is some information in our statute that we do not collect and don't plan to collect. That includes our BPO risk certificates, which are available through DOI, and community benefits information, which is available through the AGO. Because all that information is already available, we don't feel it's necessary to collect as part of RPO. We also allow for attestation when information is available through another state agency. So, for instance, as part of the upcoming 2019 filing, there's going to be a big overlap between the financial statements that we collect in RPO and the financial statements that CHIA already collects. So in the event that a provider organization has their required financial statements on file already with CHIA, we will let them attest that that is the case, and we will consider that requirement satisfied for RPO. And we also aim to minimize duplicative reporting across provider organizations within the RPO files themselves. This comes into play mostly in the clinical affiliations file and the physician roster file, where there are relationships and physicians that may otherwise have been reported multiple times, but we've designed the data elements so that to ensure that they'll all ultimately only be reported once. A big piece of all this is our alignment with CHIA that took place back in 2016. Chapter 224 included two similar sections in our statute and CHIA statute, which included similar reporting requirements, the same provider organizations, a lot of the similar data elements, but included different timelines and different processes for approval. Also, all of our statute was already part of CHIA's statute, so we viewed that as an opportunity for some program alignment. So now provider organizations have a single staff contact here at the HBC. They all use one login, one password. They use the same submission platform every year. And we were able to eliminate off-cycle updates, which were previously part of the RPO HBC plan. And then finally, our goal of balancing the value of collecting data versus the potential burden to the provider organizations for reporting that data. We do routinely reevaluate questions. We've removed data elements, for instance, a service lines question in our facilities file. We removed after provider organizations told us that the information wasn't particularly reliable because of how often it was changing and because of the burden that was put on them collecting the data at the level that we had asked them to collect it at. We've also removed entire files. The APM and other revenue file was a file we added for the 2017 filing, but we've removed for now going forward. We also continue to consider competing priorities that provider organization staff might have. For instance, when the MassHealth ACO launch was a priority in 2018, for RPO we decided not to add any new data elements for that year. Also based on reporter feedback, we moved our filing deadline from the fall to the summer because we heard that that was an easier timeline for our reporters. And we also continue to engage regularly with our reporters and end users of the data to prioritize areas for data collection and also to gauge the areas that might be most burdensome for the provider organizations to collect. So a quick summary of our successes and the opportunities that we've identified. We talked a bit about our success with our alignment with CHIA. Our willingness to evaluate and remove questions and files when they prove to be low value, I think, is a strength. Liz highlighted the different organizations that have used our data externally and the teams that have used it internally as well. And we've only heard good things about our successful customer service. We We have the survey data to back that up. I swear I'm not just saying it because we're the customer service. Some of the opportunities, removing the low value questions that we have removed, I think is a positive, but it would also be ideal not to put those in the first place. We do test all of our questions with our provider organizations and end users, but there's still going to be a misfire from time to time. Now that the program has a foundation underneath it, we think it would be great if we could get more of a lead-in to when we add and phase in new data elements, perhaps a 2-year period, to allow the provider organizations to prepare for new requirements. We also want to have a sharper focus on looking for areas where we can pull in data from existing data sets rather than collecting anew as part of RPO. Data release, right now we pretty much just put our files up on the website and let anyone use them however they choose. We'd like to expand, have some more interactive data releases, or some data releases that answer specific questions that RPO can answer. And finally, considering the success that we've had with our alignment with CHIA, we want to look for other alignment opportunities with other agencies and programs, which I'll talk a little bit more about in a bit. And then this slide just quickly goes through what's new for our 2019 filing. First, I already mentioned that provider organizations can now attest that their financial statements are already on file with CHIA. In the facilities file, we've added 4 new data elements regarding inpatient bed and emergency department services at hospitals and clinics. All this information has been pre-populated for the provider organizations with data from DPH. So all our reporters have to do is log in and verify that the information is correct. We've also added 1 new file, the payer mix file, which will collect payer mix information from physician organizations and will complement the already available payer mix information that's available at the hospital level. And then finally, considering our alignment with CHIA, we do want to look for other opportunities to align with other agencies and programs, our BPO, the ACO program, the RBPO appeals program, among others. So we're putting together a team to dig into that question and hopefully identify some opportunities and come out with a plan in the next 12 to 18 months for how we can align these organizations and towards the goal of reducing administrative complexity. And finally, just a quick snapshot of our timeline for the 2019 filing. We're obviously getting close to the end here. A reminder for everyone that the 2019 filing is due July 31st by 5 p.m., so just a couple months to go. But as Liz mentioned, the online submission platform is open, so all of our provider organizations should now be able to update their information and attach any necessary file attachments. So that's our RPO update. Happy to take any questions if there's any time.
It's great. I'll just say, in the early years of the program, I heard 2 types of complaints. One was, this particular thing is a little bit taxing and everything like that. And second is, why on earth does the Commonwealth require us to do this at all? I think in the last couple of years, I haven't heard any complaints on either line. So obviously, the second of those complaints is just the nature because the Commonwealth wants it and they don't want to do it. And the first one, I have not heard any complaints recently, so I think that was a good sign.
Thank you.
I think Rick wants to join us. Yeah.
So like David, I remember in the early years too, I used to hear occasional complaints from some of the providers about the complexity or the fact that they already submitted the data to other agencies, and again, I haven't heard any of that. And I'm so impressed by this presentation and that you're continually rethinking, what you need to collect and how it's to be used, and if you find that's duplicative or there's better ways to do it with other state agencies. I just I was going to ask a lot of questions around that, and you're already way ahead of me, so I congratulate you all. It's great.
Thank you. Great. So now we're going to shift our focus to a very timely health policy topic in terms of issues around the prescription drug market. So first, before we dive into some new research that we're very excited to present, on the role of pharmacy benefit managers. Before we move to that, did want to just take a few minutes to give an update to this committee on another one of our research projects legislatively mandated around the study and use of drug coupons. And so we'll give just a brief update on that. Commissioner Cutler, you attended a listening session where we walked through some of these slides, so these will be a little repetitive for you, but we'll try to move quickly and then get into, I think, a topic that everyone has a lot of interest in, which is the PBM research.
Okay, great, thank you, David. Okay, here we are. As David mentioned, we gave an overview of this project earlier, and also shared some details at a recent listening session. But with this presentation, I'd like to provide a little bit more detail on our framework for our research on use of drug coupons, and also share some of our takeaways from the listening session. So I'll just set the stage a little bit with some important definitions for how we're thinking about coupons. These are the way that we are looking at it for the study. We're looking at a narrow section of all possibilities of patient assistance. What we're calling coupons are those coupons that are offered by manufacturers to reduce the amount of a patient's cost sharing. For commercial patients, these might be called coupons, vouchers, copay cards. Important to note that public payers, Medicare, Medicaid, VA, do not allow the use of coupons. Here's some illustrative examples. What we have here for a flow is using an example of a patient who has a cost sharing of $610. How this might work in practice is the patient downloads a coupon from the manufacturer. The patient brings this coupon to the pharmacy, gives the pharmacist their $300 coupon in this case, and the balance $310 in cash, for a total of meeting their $610 liability. They pick up their prescription. The pharmacy reports to the plan that the $610 liability was met. And what we heard at the listening session, some of the questions were an interest in more detail on the flow of that data from the pharmacy to the plan, and that's definitely something that we will incorporate in our work moving forward. Some context on the study is important here. So this has been a long-standing area of interest in the state, starting with 2012. Massachusetts was the last state to allow the use of coupons. That was put into place in 2012, but with some important caveats. Firstly, that coupons are not eligible for use for drugs that have a direct generic equivalent, and also that this was put in place temporarily. It had a sunset. That sunset has been pushed back a number of times in legislation, and finally that brings us to today's charge, an act that passed in 2018 that would do two things: delay the sunset until January 1st, 2020, and also directs us to study the matter and report our findings before that sunset. Okay, so what are we asked to do? This is a summary of the language. So analyze the total number and value of coupons for which types of drugs. How do coupons impact use of generic alternatives? Again, this is not a direct generic alternative, but other close substitutes that a patient might use, alternative brands. How does this impact patients, patient adherence, and access, importantly? Also, how long can these coupons be used? When do they expire? What is the impact there? And then moving from the individual to a system-wide approach on the impact of drug coupons on the Commonwealth's cost containment goals and premiums for overall commercial population and for GIC in particular. Okay, this is a framework that I I want to share for how we are seeing the world. This is based on a paper that came out of University of Southern California. So there's four buckets here. The target is a drug. This is always a branded drug that has a coupon. The first is where that drug has a direct generic equivalent. These are, again, not eligible in Massachusetts, but that exists out there in the world. So Lipitor and generic Lipitor. The second is a particular area of interest. This is where the drug itself with the coupon does not have a generic equivalent, but it has others in the same class, close therapeutic substitutes that a patient might discuss with the doctor about, which of these might be best for me, and some of those alternatives are generic. So the third is where the drug with the coupon does not have a generic alternative in the same category, no close therapeutic substitutes, but there are other alternatives, and those alternatives are branded. This one can be a little difficult for us to study because the competitors may also offer coupons. And then the fourth is where the drug with the coupon has no close therapeutic substitutes. This is where we might call them orphan drugs, and that's a different choice for patients. They don't have that sort of. There is no conversation in that case for sort of which of these is best for me with their doctor or clinician. Okay, so our timeline to complete this large body of work is takes us to where we are in June. We just completed our public listening session in May. We have been working on acquiring a robust set of sources to use, including options for commercially available data that might help us assess questions like the total number of coupons value that we wouldn't have from our all-payer claims database or other sources at our disposal. We are planning to present preliminary results of our work at the July board meeting, and then aiming to release our final report at the September 11th board meeting. Finally, I wanted to share some of our takeaways from the listening session we had on May 21st. We heard testimony from plans, from associations, from patient perspective, from the New England Hemophilia Association. We've received additional written testimony from manufacturers and their advocacy organizations, as well as a joint letter from 26 organizations, predominantly patient advocacy organizations. And these materials are all publicly available on our website, as well as a video of the listening session. So just wanted to share some of the key takeaways. I think that there was broad consensus that costs of prescription drugs are rising, and that patients face high financial burdens from deductibles and cost sharing, particularly certain subsets of patients. So I think those are pretty well established. However, there are diverse perspectives on other questions, such as how big are the impacts, what are the impacts, and different perspectives in which factors are most important. How do you balance competing considerations? So there were some sort of technical issues raised, questions for us on getting more information on specific coupon design, and those questions of expiration, etc., and then some conversation about the lack of visibility of coupon data to payers and the public. So all of which we are planning to incorporate into our study, and we look forward to presenting our preliminary results in the future.
I'll start off with the discussion. I'll start with the discussion by offering just a couple of comments on the listening session, which I found extremely enlightening, and I thought all the testimony say, there were a couple of interesting things that came out of the listening session for me. One was at least some of the people using coupons are not using them so much to lower their annual medical spending because they're going to reach whatever their out-of-pocket cap is, but they're using them to move the spending from early in the year, like January 3rd, to later in the year, like March 3rd. And that's a benefit because they've got all their out-of-pocket costs coming through. So if you have someone with, in this case it was a child who had very, very severe expensive illness, so you're going to hit whatever your maximum is within all the bills are coming due in January, so this helped them spread out the bills over a little bit of the year, even though they were clearly going to hit your maximum anyways. And it struck me that there was this sort of that there was a failure here, which is the insurance company should be smart enough to say, look, we should make you pay all of your $6,000 between January 1st and January 10th. We can spread that out for you because we know that you're going to get this $6,000. So there was a part which is the coupons were just doing a function that you think the insurance company ought to be able to do. Was one thing that came through. I think the second thing that came through to me is Sarah stressed this some, which is that the coupons are increasing in importance, and I think this is happening for a number of reasons, but which makes what we're doing even more important. But two in particular. One is there are all these sunshine laws cracking down on pharmaceutical companies marketing to physicians. So it's very difficult. Many physicians and physician organizations won't let pharmaceutical companies in. And so if you can't go to the physicians, you go to the patients. And then that means you either advertise on the TV, which is sort of general advertising, or you try to target particular people. And so the couponing is actually getting to be an immense thing. Sort of, I had thought of it like a few years ago as a sort of fringe thing, like there were products that had coupons, and now it's just like strategic couponing is as big as the deal as what TV shows do you advertise on and what magazines are you in and so on. So this is, I think, a super important matter for the state. I also think another thing driving it, and the two are related, is that the co-pays for many very expensive drugs have gone up in plans a lot. So you now have specialty tiers where maybe the patient is responsible for 30% of the cost, or $5,000 out-of-pocket max where the drug isn't covered very well. So you sort of hit that at some point. And that's a really big deal. And what you got in the testimony, some of the folks saying that the health plan saying, look, we set our cost sharing optimally to encourage use, and all these coupons do is distort what we're trying to do. What we're trying to do is good, so don't let them distort us. And then on the other side, you have the folks, particularly the advocacy groups, saying, look, they're in essence discriminating against us. They're keeping the premiums low by making us, sick people with sick kids, pay a lot, and why should we let them do that? And the copay is a way to balance us against that. And so some of this depends to an extent on whether you think that in essence, the plans will get the right cost sharing, so the coupons are a distortion to the plans getting the right cost sharing, or whether you think the plans will get the wrong cost sharing, and the coupons are a way of putting a little more balance into the patient side of the equation from that. I don't know enough about the specific plans here in Massachusetts, but nationally I think there's a big tendency for plans to raise cost sharing on sick people as opposed to premiums for healthy people grow. That's not so great when you pose it that way, but that's what they're doing. And then you say the coupon may be a valuable way to offset some of that. That debate I think is playing into it. And then just maybe two final observations. One observation, what many of the plans complained about, they said, well, look, we can understand if the pharmaceutical company wants to charge patients less, but doing it for only one or two prescriptions for a chronic medication clearly is not optimal, because then the patient's just going to be stuck with these very high bills, and then we're going to get these complaints from patients saying, I started on now I have to pay a gazillion dollars for X, and why are you making me pay a gazillion dollars for X? And their answer is, well, you shouldn't have started with X, and that's less fulfilling than, look, here's a better drug for you to start on initially. So there's a temporary nature to the coupon that's also of interest to the plans. And then the final thing I'll say is, I tossed out maybe, and I don't know if it makes any sense, but I just want to follow it up as a question, that to the extent that what the coupons are doing is shifting people from drugs that are just as effective but cheaper into drugs that are the same effectiveness but more expensive, maybe in addition to the coupon for the patient, there ought to be a coupon for the insurer. That is, say, okay, fine, if you want to do that, but you can't make it cost any more to the insurer. So, you know, if it's drug A, drug B, and you have to do drug B as opposed to drug A, well, then you got to give the rebate to everybody. So you have to lower the price to the insurer for those people who you're switching from one to the other. So I don't know if that'll go anywhere, but that was some of the thoughts that occurred to me after reading all of this and but I thought it was super helpful, and it's even, I've concluded it's even more important than I thought. They clearly struck a nerve with me, so maybe not the info. That's the Manufacturer Association.
More to come on this topic. As Sarah said, we are hard at work. We are using our claims data as well as hopefully acquiring some data that will answer a lot of these questions about which drugs the coupons are being offered to whom, how long do they last, what is their value, and I think that will provide a lot more information to the public and to policymakers about the policy of allowing these types of coupons to continue. So this is I think really important work and something that the legislature and the administration prioritized for the Health Policy Commission to take on, understanding that it is a complicated topic and one in which there is not actually a lot of current research or evidence base to draw from. So this will be groundbreaking work for us moving forward. So with no other comments on the drug coupons, I do want to move on to our next topic, which is new research that we have conducted into the role of pharmacy benefit managers in prescription drugs and the cost of prescription drugs. And I guess I would just tee this up really quickly. We had 3 prescription drug topics on the agenda here today. The first, coupons that you just heard about. The second, where we'll be talking about pharmacy benefit managers and their pricing practices. And then the third topic at the end of the meeting will be around different distribution mechanisms for specialty drugs and specialty pharmacies. I think a common theme across all 3 of these topics is how opaque and convoluted the prescription drug market and drug distribution chain is. And ultimately, we are trying to untangle the flow of dollars across multiple different organizations, across multiple different places on this chain. And as Sarah will show you in a graphic in a few minutes, this is much of this is purposefully hidden from the public, and we are attempting to bring sunlight and transparency to this topic for the first time. I would note that prescription drugs and the impact of rising prescription drug costs is now a national conversation. This is a conversation that is occurring in capitals and state houses across the country. It is a conversation that is occurring in Washington, D.C., both from the president, from Democrats and Republicans, and on some of the issues that we're going to be discussing today, a growing bipartisan consensus that policy action must be taken in order to protect ultimately patients, taxpayers, employers, and all of us who end up paying the cost of healthcare. So we have really taken this challenge on at the Health Policy Commission. As all of you know, the issue of rising prescription drug costs has been a theme and a topic at multiple cost trends hearings. We have made recommendations in our cost trends reports over the years around different policy solutions to try to moderate the growth in prescription drug costs. And so we undertook this research study in that same light to try to, again, identify those opportunities, and in this case, identify areas of particular concern where we may see inappropriate behavior that is ultimately leading to higher costs for health plans and ultimately for patients. I would also acknowledge at the top here that this is a topic that the legislature here in Massachusetts has had a lot of focus on. Some of the issues around prescription drug manufacturers and pharmacy benefit managers were issues that were included in proposed legislation last year in last year's session that ultimately was not adopted. And would also really acknowledge the Baker-Polito administration and Secretary Sutters, who have also made this issue a top priority in their agenda for the year. So with that as an introduction, a broad introduction to this topic, I'm going to turn it back over to Sarah to walk through our research on this topic, and really hope to get some feedback from you commissioners on the findings and where we can go next with this issue.
Okay. Great, thank you, David, for that introduction. So with that introduction, we're going to talk about a pharmacy benefit manager, or PBM, pricing practice called spread pricing, and its potential implications for drug spending in Massachusetts. That will be published today in our latest installation of our DataPoints publication. So prescription drug spending continues to drive healthcare costs in Massachusetts. She has estimate of 4.1% growth, that's net of manufacturer rebates and discounts, and drug spending continues to be a major issue and area of focus for the MassHealth program. So So that leads us to focus on this topic. Addressing drug spending requires a focus on all parts of the drug distribution chain, including PBMs. PBMs manage prescription drug benefits for many health plans. They provide a number of important services, negotiating prices, rebates with manufacturers, and payments to pharmacies. They do provide a number of important services. We'll get into that a little bit, but this research focuses not on the services, but on how they're getting paid. And in particular, a focus on facing scrutiny for a practice of what's known as spread pricing for generic drugs. This is a generic drug market issue. So under spread pricing, PBMs charge payers for a drug, in some cases substantially more than what they are reimbursing pharmacies. We know that PBM use of this practice is increasing rapidly over time. It covered 22% of compensation. These are national estimates in 2014, rising from 22% to 54% in 2016. So particularly because there is not a lot of information, not a lot of transparency, this practice has raised concerns about the potential impact on value for both public and private payers, and contributions to high drug spending overall. So this was what drove our research to look at the potential impact of this practice in the MassHealth managed care program and So this chart shows the complexity of the drug distribution chain. I think complexity is definitely the key word here. And shows PBMs as only one of many players that are important to look at. This slide here is a distillation of information that we received from plans in Massachusetts through our pre-filed testimony in conjunction with the cost trends hearing. So this slide shows the relationships between which plans, which PBMs, and the services on the side. It's clear that PBMs provide a range of important functions in Massachusetts and nationwide, I think that stakeholders can have sort of a negative brushstroke of being called a middleman, and that's not what we want to say here. There's clearly a range of important functions, and again, this is not about the services, but how they're getting paid for those services and where's the money going. Okay, so for this, I am going to turn to Swaya Gadam on our team to help us illustrate how spread pricing works and what it is. So we're going to switch over to our interactive Tableau model. Okay, so the first line, all complicated concepts start out with one line. So in this illustration, so the pharmacy purchases a drug for $2. In this case, that's their acquisition cost of acquiring the drug. Click through to the next one. So when a consumer uses their insurance, no, sorry, one back. Blur. Having some technical difficulties. I'm just gonna. Okay, so now we have two lines. So when the patient uses their insurance to fill a prescription, the PBM reimburses the pharmacy for that drug. In this case, $5, allowing the pharmacy to earn $3. The difference between those two lines. Can you click through to the next one? So the third line here is what the PBM charges the payer, such as Medicaid Managed Care Organization or commercial insurance employer plan for that prescription, $14 in this case. So can you click through to the next one? Thank you. So the difference between that $14 and the $5 reimbursement is a $9 spread. That is shown in yellow here. That's what the PBM keeps as revenue. It's the difference between what the plan paid and what they paid the pharmacy. So they're keeping that. So they're keeping $9. Pharmacy gets $3. So that's sort of the spread pricing concept in a nutshell. Can you click through to the next one, Svea? So this one is, the charts get a little more complicated. The difference here is just to show some dynamics. It's not all straight lines. The bottom line, the pharmacy's acquisition cost for the drug, varies over time. Those things can fluctuate up and down, often down, sometimes up. So there can be fluctuations in the cost of the drug to the pharmacy, fluctuations in what the PBM pays to the pharmacy, the next line up, and fluctuations, changes in what the PBM charges the payer. So the blue there is what the pharmacy earns as profit. When it's a big band, they've made more. When it's a narrow band, they've made less. And it's also possible that these lines cross. It's also possible that the PBM reimburses the pharmacy for less than the acquisition cost, and in that case, it wouldn't be a narrow profit, but in fact, actually a loss.
Sarah, this is illustrative
these are illustrated with hypothetical numbers. The real numbers will be coming to you soon. Okay, can you go through to the fee-for-service ones there? So I'm going to talk about here a different model that contrasts with spread pricing. This is the pass-through reimbursement model. In this model, PBMs charge payers the same amount that they reimburse pharmacies. There's whatever they pay the pharmacy is what they charge the plan. So if the pharmacy purchases the drug for $2, and let's say there's always a set $10 dispensing fee, the PBM charges the payer $12. So this says fee for service because Medicaid fee for service plans are mandated by CMS to use this model. The mandate started in 2017. They have formulas vary by state, but they're mandated to pay the acquisition cost plus in Massachusetts a $10.02 dispensing fee. I do want to note that MassHealth uses PBMs in the fee-for-service program just as a claims administrator, not for all of those other services that we talked about earlier. The state does those functions themselves. So I want to point out here that $10 may not be the right amount necessarily, but this model has full transparency about where the money is going, what the pharmacy is getting, what the PBMs are getting. There might be, not illustrated here, but some set administrative fees set in contracts, and that is not the case in the spread pricing model. I guess I'll sort of, it's a little bit tricky to walk through. I'll take a breath in and see if we can ask questions. Okay. Can I just switch back to the slides? While the slides are coming back up. Oh. Okay. So what's important here is that we don't know how much with spread pricing. We don't know how much money is going to the pharmacies, but anecdotes from other states and within Massachusetts suggest that spread pricing often results in low reimbursements to pharmacies. That can be particularly hard to absorb for independent pharmacies, for pharmacies that serve a large share of Medicaid patients, and that reimbursement can affect the viability of pharmacies to stay open in neighborhoods that have a high share of Medicaid patients. So low pharmacy reimbursement can potentially hurt access to care for Medicaid patients. And I'll read a quote here that's been in an earlier story report from a Boston area pharmacist. Everyone says that drug prices are going up, but historically my average revenue per fill has been going down. So with this context, that led us to investigate potential scope of these practices in the managed care market and commercial markets in Massachusetts. Here I'm going to turn this over to my colleague Yu Huang to walk through our methodology and our findings.
Great. Thanks, Sarah. So here we have the data sources for the payer prices and the drug costs. So for MassHealth prices, we're using a publicly available data set from CMS that includes the spending and the utilization for fee-for-service and MCOs. The latest time period is the last quarter of 2018. For commercial prices, we're using the APCD. The most recent time period available is 2016. And for the pharmacy acquisition costs, we're using NADAC, the National Average Drug Acquisition Cost data from CMS. This is based on a nationally representative survey of pharmacies around the country and a widely accepted and used data source for drug acquisition costs. pharmacy acquisition cost of the drug as well as how much PBMs are reimbursing the pharmacy for these drugs. However, because there are no publicly available data on MCO data on PBM reimbursements to the pharmacies, this is how we're approaching the analysis. So in MassHealth, as Sarah mentioned, fee-for-service price is based on the drug acquisition cost plus a dispensing fee of roughly $10. And again, we're not suggesting, whether that is what should or should not be paid, but because this model is fully transparent, we can use fee-for-service as a benchmark to assess the PBM prices in the MCO program. And then in contrast, and at times we also compare the MCO prices with the NADAC, the drug acquisition cost. So I'll sort of switch back and forth between these two methods. It's a little bit confusing, but I'll try to be as clear as possible in walking you through the results. And in the commercial analysis, in contrast, we are here comparing the average prices commercial payers paid for the drug and the drug acquisition cost. So the difference between these two includes both the dispensing fee that's kept by pharmacies as well as the revenue that's kept by PBMs. So again, we cannot discern exactly how much is kept by PBMs, but seeing these amounts will give us an indication of how large the spread might be. And in both of these analyses, we are looking at generic oral solids only. And just one important aspect of the MassHealth analysis we wanted to note is that MassHealth MCOs are paid a capitation rate. So when MCO price is higher, it does not necessarily contribute to high state spending in the short term directly, but in the long term, if MCO drug price is high, that could lead to fewer resources that MCO could spend on other medical benefits, and it could eventually lead to higher capitation rates in the long term. So here are the results for the last quarter of 2018 for MassHealth, which is the latest time period we have available. So first, we compared MCO price with the drug acquisition cost. And we found that MCO price was higher than the acquisition cost for 95% of the drugs that we looked at. And then, going back to the approach of using fee-for-service as a benchmark, we found that MCO price was higher than fee-for-service price in 42% of the drugs we looked at.
Can I ask you a question?
Mm-hmm.
Do we have to think about rebates in this?
We don't, because these are mostly generic. These are generic drugs.
They're all generic.
Right, so we don't have to worry about the influence of rebates in these scenarios. So here we're comparing the MCO price with the fee-for-service price, and we found that MCO price was higher than fee-for-service in 42% of the drugs. So while MCO price is higher for less than half of the drugs, we found that when the price was higher, the difference is often very substantial. So if you look at kind of the top of this pill bottle, there's about 10% of the drugs we looked at, the MCO price was higher than fee-for-service price for $50 or more per prescription. So this is an area of focus for the rest of my presentation, where we'll take a deep dive on some of these drugs. We'll go to the interactive graph next. So here we have a bubble chart showing the drugs where MCO price was higher than fee-for-service price. So these are generic drugs that are covered by both programs, and you can see, so the size of the bubble represents how much higher MCO price is compared to fee-for-service price, and the color of the bubbles represent the number of MCO prescriptions. So the darker the bubbles are, it means more prescriptions for that drug. So it's just hovering over that big bubble. For example, for that drug, the difference between MCO price and fee-for-service price per prescription was over $1,100. Okay, then next we'll take a deep dive on some of these previous bubbles. So this is a bar chart looking at the generic drugs with the highest price difference between MCO and fee-for-service on a per prescription basis. So at the top we have lenacapavir, which is an antiviral drug, where the difference is $1,134. So, and just a reminder, we know that fee for service is based on drug acquisition cost plus $10. This is showing the MCO price is $1,134 over that.
Per prescription.
Per prescription, right. And again, we don't know how much of this $1,134 is going to the PBM and how much is going to the pharmacy, but seeing numbers like this, it certainly raises questions about where the MCO money is going. So these are charts that are on a per prescription basis. Next, we'll go to the aggregate numbers. So here we have a combination of drugs. Some of the drugs had high price difference between fee-for-service and MCO, MCO and fee-for-service on a per prescription basis. And we also have drugs where the difference on a per prescription basis is not quite as high, but the volume of the drug is really high. So that is the case for the drug on top, which buprenorphine naloxone, which is the generic version of Suboxone, and as people know, that is used in the treatment of opioids disorder and a critical component of solving our current public health crisis. The drug here, in the last quarter of 2018, the fee-for-service price for this drug per prescription is $76. And for the same drug, one prescription, MCO is paying $161 for this drug. So that leaves a difference of around $85 per prescription. And when you have over 3,000 prescriptions in the last quarter of 2018, that adds up to over $252,000. So all the results I've presented so far are snapshot in time, so that's certainly one limitation of our analysis. We know the drug prices do fluctuate, so we also wanted to look at some trends in time. And when we did this, we found several cases where, in fact, the acquisition cost of the drug is falling, but the MCO price is sort of not fluctuating with the drug acquisition cost. So here again, we're moving away from using fee-for-service price as a benchmark, and we're going back to comparing MCO price with the acquisition cost of the drug. And here again, we have generic Suboxone, and the line here, the blue line, is showing the MCO price for this drug in the past over 2 years. So this is starting in the first quarter of 2016 through the last quarter of 2018, and this is showing a per tablet price. So as you can see, the blue line is the MCO price, and the orange line is the drug acquisition cost. You can see that over the course of 2 years, the cost of the drug acquisition cost is steadily dropping, while the MCO price for the drug has actually increased in the past in those 2 years. And we found several other cases where this is the case, where you see the orange line either dropping or staying flat over the course of 2 years, but MCO price is not changing, is not falling with the drug acquisition cost. So yeah, you can go back to the slides and just go to the commercial results.
I'm gonna click through this, but just the data point, the tableau is a little bit hard to see. Just wanted to make sure that the audience could see the numbers here. That generic Suboxone was the drug with the highest aggregate spending difference, so excess spending of over $250,000 in the fourth quarter of 2018. This is the line charts for generic Suboxone.
Okay, so here are commercial results. We know that the practice of spread pricing is not limited to MassHealth MCO, so we also looked at the commercial market, and these are results from the last quarter of 2016, which is the latest APCD data we have available. So here we have on the top tacrolimus, which is a immunosuppressant, and you can see the number is $2,350. So here, we are comparing the average price that commercial payers paid for the drug against the average drug acquisition cost. And the difference between those two numbers are $2,350 per prescription for this drug. And just wanted to remind you again, for this number, we don't know how much of that is going to the pharmacy and how much that is going to the PBM, but certainly the number here is noteworthy. And moving from the per prescription results to the aggregate results, here on in the last quarter of 2016, we have imatinib, mesylate on the top, which is a cancer drug. The difference between the commercial price and the drug acquisition cost is about $1,800 per prescription, and with just over 150 prescriptions from that quarter, that added up to almost $280,000. So this drug is an oral chemotherapy drug that's used in the treatment of leukemia and other conditions. And in this analysis, while we didn't specifically look at cost sharing, we know that often patients' out-of-pocket costs are proportional to the price of the drug, particularly for patients with co-insurance and high deductibles. So particularly given those patient experience, these numbers really are quite striking because it shows how much the price of the drug are not necessarily tied to the drug acquisition costs. Okay, I will turn it back to Sarah for conclusions.
So we're not the only ones looking at this issue. A number of states and the federal government have taken or are pursuing action. So a number of other states are acting to require PBM licensure, greater disclosure and transparency. We don't have information at this point about where the money is going, but Ohio did. Ohio is was the first state out of the gate to ring the alarm bell on this, and their auditor found that PBM profit accounted for just under a third of their total managed care spend on generic drugs, 31%, and they have subsequently ended their spread pricing contracts and switched to a pass-through model for their managed care plan. In Massachusetts, the administration has taken a number of steps, proposing a new requirement for PBMs to be transparent about their pricing, limiting PBM margins in contracts with MCOs and accountable care organizations with an estimated savings of $10 million. And then a recent tangible step to gather information, releasing a bulletin in April requiring MCOs and ACOs to collect and report data from PBMs, including payments to pharmacies. In the federal space, CMS released guidance just a few weeks ago aimed at limiting spread pricing in their Medicaid and CHIP contracts through defining how managed care plans need to report PBM spending, reclassification of that spending. So, wanted to conclude with some of our key points and some final thoughts. The MCO price was not always higher than the fee-for-service price, but where it was, the difference was often substantial. The particularly noteworthy example of generic Suboxone, finding that the MCO price was more than twice the average fee-for-service price per prescription, leading to the excess spending for that drug, leading to its number one rank in spending difference. And where you see that kind of excess spending, it certainly raises questions about the practices of the PBMs that have been trusted to run the drug benefit for these programs. Anticipating questions from commissioners, we've heard from PBM industry that they don't need to be paid under spread pricing. They can be paid. Many different contracts are all various and compensated for their services, and that spread pricing models have some advantages for payers. They provide predictability in shielding payers from those fluctuating acquisition costs, and that's certainly a valid argument. We just need to open the black box, and with that greater transparency and spread pricing, payers can determine what the right compensation is for pharmacies, what the right compensation is for PBMs, and help payers be good stewards of both premium dollars and tax spending. And we'll conclude there and look forward to questions.
What kept going through my mind and listening to it is the word disgusting. And I think this is something we all need to focus on. And the quicker the better. People are really getting hurt with this. And it's clear that organizations are taking advantage of the public.
I will add, thank you, Commissioner. While other commissioners are thinking of comments and reactions, I would note here, we titled this particular analysis "Cracking Open the Black Box." Perhaps a more apt title would have been like "Peeking into the Black Box," because it certainly strikes me that these findings raise a lot more questions and certainly reinforce the need for greater transparency to truly understand the flow of these dollars, who is potentially profiting on the backs of these very large differences in the cost of the drug versus what the price is being set at, and to ensure that it is not inappropriate, to your comment, Commissioner. So while we certainly did and used our unique data sets to bring these new insights, it does strike me that there is certainly more that needs to be done and more information that needs to be gathered, and want to highlight that the administration has required the Medicaid managed care organizations and ACOs to submit more information to the state on these contracts and exactly what the margins are. But certainly want to reinforce that there is a need for further policy action in order to address this topic. Professor Cutler?
This was an amazing presentation. I was thinking along the same lines as Ron. I guess I want to just ask a couple of factual questions. Can you go back to slide 50 for 1 second? Yeah. Do you have have you added up, like, for about half the drugs, the MCO exceeds 50%, and for about half the drugs it's lower? I'm just wondering if you added up, like, how much is the total greater in the MCO than in the fee-for-service?
We did look at this question for, I would say for a subset of all drugs, so ones that we could most easily compare that are covered by both, some sufficient size in both programs. And from that subset, actually, total spending, if those prescriptions in the MCO program instead had the fee-for-service price, total spending would actually be higher. However, the sort of an important context to have is that the fee-for-service is higher because of that it's the $10 dispensing fee that's driving the price, and we know that $10 dispensing fee is going to pharmacies. That's and it's not clear where the money is going with the MCO prices. So those are, to say it another way, it's a policy choice that can be made about how much to pay providers, like any other provider. Pharmacy is a provider, and the total spending could be dialed up or down depending on what those inputs are, as long as the inputs are known.
So if you kept the $10 fee, it would be
why that is a little bit different than this distribution here is because this is just unique drugs, drug, and when that calculation was done on the basis of a weighted average of the, where the volume of prescriptions are.
And then the other way to ask the question is, if you said, well, sometimes you negotiate a better price than fee for service, that's fine. But what we're gonna do is we're gonna put a limit, you can't charge the state more than the fee for service price. So if you just brought the MCO prices down to the fee for service price, do you have a sense about what percent that would save?
You would start from that top line of, here's how much higher fee for service is, and you can dial it down any way you would like. But I think for a proposal like that, you would want to be careful about, making sure that you have the transparency.
I just want to take that step on the top right and just say, okay, if you said you can't be higher than the fee for service, how much lower do you get? We may not have the
could look
answer.
at that, yeah.
We may not have the answer. I'm just trying to get a sense of how we do that. Thank you.
I would just note that as Sarah mentioned, we did issue a bulletin in April directing the MassChallenge HealthTech entities to provide more information. And we expect to have those reports by July. So I think at that point we will have more data than we have had in the past to answer some of the questions.
But we're not going to do it justice. Should we try and squeeze in the, we should try and squeeze in the third-party specialty pharmacy.
Our prescription drug trifecta. So we have just about 10 minutes. Just about 10 minutes left here, and this is another complicated issue. So I'm going to ask Sarah to do her best to try to both remind the commissioners of the context of this study. We did go through this in depth at the February committee meeting, and then really focus in on what our potential recommendations for this report would be and get any feedback commissioners may have on those. We do hope to issue this final report this month, and we'll circulate it to commissioners in advance for review as well.
Okay, lightning round for the hat trick here. So this is a review of the legislative mandate for this report. This is to study practices that known as white and brown bagging, casualty, third-party specialty pharmacies. This world of drugs here is for drugs that are typically covered under the medical benefit. These are drugs that need to be injected or infused by a clinician. All right, so I'll start out with walking through what the traditional model is, known as buy and bill. In this traditional model, the hospital or clinic pharmacy is the center of the model. That pharmacy will purchase drugs through a distributor, ultimately from the manufacturer, purchase those drugs for general use by any patient, store them. When a patient requires a particular drug, they administer that drug to the patient and they bill the patient's insurance. The hospital subsequently receives reimbursement both for the drug and a separate reimbursement for the administration of that drug. The patient pays their cost sharing for both the drug and in many cases the administration to their payer. These are again under their medical benefit. And in the commercial space, rebates can flow from the manufacturer to the payer in this model. That is not the case for Medicare. Okay, so in the white and brown bagging model, this alternative model, the payer changes this model and inserts a third-party specialty pharmacy. Now that third-party specialty pharmacy is the center. As a reminder, specialty pharmacies are are not sort of the typical pharmacy you get to sort of get your kind of everyday small molecule generic pills. They have a specialty in drugs that are, these are very high class, these are sensitive, sometimes they need to be kept cold at every point in the chain, they have special requirements. Some of us have had interaction with these if we have medication, often for self-injection, for example. So that third party specialty pharmacy is responsible for acquiring the drug from the distributor manufacturer for that specific patient. On the left arrows in sort of a darker orange are brown bagging. With brown bagging, the pharmacy ships the drug directly to the patient, who then needs to bring it to the provider to be administered. There's that visual of carrying a brown paper bag. White bagging, in contrast, is on the right. That is where the pharmacy ships the drug to the hospital clinic pharmacy for them to store for that patient and gets administered. In this case, the payer reimburses not the hospital or clinic pharmacy, but the specialty pharmacy gets the money for the drug. The clinician is reimbursed only for the administration. The patient pays their cost sharing to the payer. This is covered under the medical benefit. Under the pharmacy benefit, they have a cost sharing structure that is laid out in their pharmacy benefit, which is often a different cost sharing structure than in the previous case. So our report looked at the implications of this practice, both financial implications, what the implications of patient safety and access to care, other unintended consequences, what are other what's going on in our fellow states, federal government, and finally made recommendations. So had a robust study approach, looked at both commercial and Medicare. I'm just going to try to go through our key findings and hit just sort of the highest points. White bagging has become relatively common. Brown bagging remains uncommon. And indeed, in Massachusetts, some payers require white bagging for certain. No payer required brown bagging. Some payers required white bagging for certain drugs. Some payers required home infusion, which we also looked at for certain drugs. The payer exception policy is important to spend a precious minute on, because you can have your policy, but how flexible are they when patients have specific needs? There was quite a variation. Some payers only allowed exceptions if the patient met medical necessity criteria. Some allowed no exceptions at all for white bagging or for home infusion. Blue Cross Blue Shield had a particular policy of interest of offering a site-neutral payment policy. There's which they structure through a variety of mechanisms, but the idea is that the provider can continue to buy and bill, but they get the lower specialty pharmacy rate. So it's a lower revenue stream, still have a revenue stream, and addressed the safety concerns that providers have that I will lay out. I'll start with the financial implications. So we did find in the commercial market that that white bagging was indeed substantially lower prices based on the drugs we looked at, 12 to almost 25% lower in that particular year. That's consistent with national estimates. Cost sharing was relatively similar for white bagging and buy and bill for the drugs that we looked at, and overall amounts were relatively low. We pretty much just were able to look at Blue Cross Blue Shield in this case. However, some patients, there was a minority of patients who faced high cost sharing under buy and bill that likely reflects whether they had met their medical deductible yet. People with a high deductible. Really important point to emphasize that for both buy and bill and white bagging, the total patient implications depend on the price of drug and the benefit design. Different story in Medicare, and patients have the potential to be exposed to much higher cost sharing. Safety and access. Brown testimony findings were virtually unanimous that this is brown bagging cannot safely be brown bagging program cannot be safely administered. Home infusion findings were mixed. This safety concerns generally focus on lower level of expertise, but for some patients this is a attractive option and it works for them safely. Again, white bagging findings were mixed. There were a number of concerns that providers expressed. However, there are some cases where white bagging can improve access, particularly for smaller providers, and also with best practices. Some providers noted they were able to run safe and effective white bagging programs. Some of these best practices are noted here, also best practices for the pharmacies and in selecting which drugs. So that leads us to our considerations for recommendations, putting together both the data on cost and also safety and access. We had 6 recommendations in total. The first is that payers should not require brown bagging for any drug. Second, payers should offer home infusion as an optional benefit but not a requirement. Payers that do choose to require white bagging should ensure minimum safety standards and capabilities in the third-party specialty pharmacies that they use. However, number 3 is in conjunction with number 4 that payers that require white bagging should offer site-neutral payment as an option. I want to be crystal clear that site-neutral policy would be limited only to those drugs subject to white bagging, not all drugs. We found that this was what we heard from providers as well, is that this did meet their needs for their comfort for safety concerns. Next, that this is sort of a broader reiteration that that action is needed to increase transparency and public oversight for the full distribution chain on the part of our legislature. And 6th, that we should put these ideas into practice for our own state employees, that the GIC and all of the connector, MassHealth, all other state payers should be first to act and should require all plans to adopt these provisions, including safety standards and providing a site-neutral payment option. And I will end there.
Wow, that was a race. So hearing no particular feedback on that, thank you, Sarah, for going through that very efficiently. So we do hope to issue this final report in the coming weeks, and we'll be in touch, commissioners, with any further feedback you may have, as well as other interested stakeholders.
I'll just offer one feedback, as we did have this session on this as well. Some of the providers were pretty open that this is happening, and they're using that to subsidize other services that they offer. I think it's a shame to make money off to make money off people who are in need of really expensive medications. So it's not clear to me that's the best way to make money. But I think this does have repercussions beyond just what's paid here. So I don't know that there's anything we should do about it, but that's just sort of stuck in my mind. All 3 of these were presentations. Does anyone have anything else they wish to add? We are adjourned until October.
I'll just add, we are going to set up for the next meeting, but we'll take a 5-minute break here, and then reconvene for the care delivery transformation committee meeting. Yes.
Thanks, Mom. Great meeting.
Lovely call, lovely Ray.
first order of business, we have the approval of 3 sets of minutes. I have a motion to approve the minutes of October 10th, 2018.
Second. Okay. I think we're gonna have to hold off.
And you weren't here in November, how about February?
All right. So, how about a motion
To approve the minutes of February 27th. This says 2000, it should be 2009.
2000? Lauren, second. All those in favor? Any corrections, additions? Okay, those are approved.
All right. We'll hold off on the others till our next meeting. We have, as I said, we have a very full agenda, plus we have a presentation by one of our Shift Care awardees. So let's get right into it with Catherine Harrison and the learning and dissemination outputs from the ACO, the latest ACO policy brief.
Hi everyone, good morning. As Commissioner Cohen has said, we do have a full agenda. The first piece here is just a quick update on a couple of new publications coming out of the Learning and Dissemination Group at the HBC, which, as you may know, spans our care delivery, policy and programmatic work, as well as our strategic investment programs. So the first is the latest in a series of policy briefs that we are releasing based on information collected through the HBC's ACO certification program. This third brief focuses on the topic of risk contracts and how ACOs manage performance under risk contracts in Massachusetts. So the first brief, just to give you a little bit of context, put out originally was just really a landscape of the ACOs. In policy brief number 2, we took a closer look at how ACOs approach population health management, including how they understand patient needs through risk stratification and other approaches, and how they develop population health management programs. And so with brief 3, we're providing a bit more context for understanding risk contracts and management of performance. So this brief covers, for example, the number and nature of risk contracts that ACOs hold. So our analysis is that at the time of certification, collectively the 18 HBC certified ACOs held 85 contracts, 70 of which were commercial and 15 of which were public payer. I'll note that these are not inclusive of the 17 Mass Health ACO risk contracts, as most of those certified ACOs had not yet initiated those contracts at the time of certification. Across these arrangements, more than 2/3 were for two-sided risk arrangements, which is noticeable. 26 were upside only, but we're seeing increasing downside risk in these arrangements as well. By our analysis, 8 of the 70 were for preferred provider organization or PPO products as opposed to HMO products. Again, that's 8 out of 70, so still relatively few that are in the PPO space. And consistent with previous HBC analysis regarding quality measures and risk contracts, we see significant variation in both the number and the exact types of metrics that are included across these contracts. The brief also describes similarities and differences in how ACOs track their performance and share performance information with participating providers, as well as their approaches to sharing risk-based incentives with those providers. Just a couple of comments on that. I think the most common approach to distributing shared savings that we saw is that distribution to participating providers based on a number of different factors, including quality and cost performance and other metrics. But a few ACOs do something a little bit different in one or more ways, such as holding individual clinicians accountable in the event of a deficit, or using other performance incentives that are not in the form directly anyway of shared savings and deficits. So that's just a quick snapshot of some of the content of this brief. This is posted now on our website.
Catherine, just one comment. Is this something we can track over time? Because I'm curious how this may change as these ACOs mature.
Yes, so in the next round of ACO certification, which will be occurring later this year, we will ask for very similar information on this topic. So we've modified and clarified some of our specific asks in this area, but that's really in order so that we can continue to make these kinds of analyses possible. Any other questions about that? All right, and then the second publication that we've recently issued that I wanted to highlight is really surfacing insights from a forum that we held last year. This was a combination of a knowledge sharing session with some of our PCMH Prime certified practices. These are primary care practices that have gone through our certification program, as well as investment awardees from our telemedicine pilots. So this was both a knowledge sharing and a discussion moderated to try to develop new information and surface lessons learned from the implementation of telemedicine for behavioral health. This guide that we just put out is really a short, highly graphical resource just meant to provide some tips based on providers' experience in implementing telemedicine for behavioral health that is directed at providers and may be useful for providers who are thinking about or in the early stages of implementing telemedicine in the context of their practices. It covers a variety of issues in the areas of workflow, data and measurement, workforce and technology, and surfaces things like how important it is to give providers time to get comfortable with technology before fully deploying it to the patient population, and making sure that the practice thinks carefully up front and clearly defines the services and the scope really of what the tele-BH offering will be, so that staff and patients are all on the same page.
And I would just add, I think we were excited to be able to put this learning document together, especially in the context of the new Medicaid rule allowing for telebehavioral health visits. And so obviously the intention is to greatly expand the use of technology in this space, and where we had some pilots that we were able to use through our investment programs, let's make sure that we're taking those learnings and being able to compile them for others to be able to learn from.
Any questions on the two documents? If not, we can move to the next item, which is program design and MassUp iterations project.
All right, great. So this is a new project that today we're hoping to introduce commissioners to you and to our audience. This is a partnership that the HPC is undertaking with several of our sister agencies, including the Department of Public Health, the Office of the Attorney General, and MassHealth, all of whom work with the healthcare community and healthcare providers in various ways. And I think it's fair to say all of whom are increasingly focusing on the upstream determinants of health. So not necessarily the medical care system, but the other social, economic, and environmental factors that influence health and well-being, both of individuals and of populations. So I'm going to take about 30 minutes to describe first some context really. I'm going to try to spend a moment on the concept of social determinants of health and how we're thinking about it and what we mean when we talk about that, as well as what we together, the HPC and these sister agencies in partnership with us, see as a need in this space, as well as how we define the opportunity here. I'll tell you then a little bit about what this project is actually before wrapping up with a few comments on next steps and timeline. Okay, so to start off in terms of context and framing, there is a strong and growing body of research that factors other than healthcare delivery have larger overall effects on the health of individual people and populations. I think we all have a sense of this intuitively based on what we observe in our daily lives, but it is worth knowing that it is not just an intuition and that there is strong research in the public health literature and elsewhere of this phenomenon. It's well borne out and documented in a variety of formats, and I think has really been recognized worldwide. The WHO and the CDC both have focused significant resources and attention on addressing the social, economic, and environmental factors in executing their public missions and obligations. And I would note also that CMS at the federal level has taken steps toward this through such programs as the Accountable Health Communities program. And here at the HBC, in our focus on promoting an efficient and high-quality healthcare system, we too have increasingly recognized this as an important area and joined with other state agencies and stakeholders in calling for increased attention on addressing the social determinants of health. We've made recommendations for increased focus on this area in our cost trends reports for the past 2 years. And commissioners who were with us in 2016, you may also remember that Lauren Taylor joined us at our cost trends hearing and spoke passionately about this issue along with several panelists both from the healthcare community and elsewhere. So we understand that these factors are a significant driver not only of outcomes for patients but also costs in our system. So to put a bit of a finer point on what we mean when we talk about the social determinants of health and the factors that lead to inequities in health, this diagram breaks down some of the major drivers. And I'll focus your attention first on the middle part of the slide with the gray boxes of categories of factors here. These categories are arrayed really from, on the right-hand side, the most downstream effect, which is clearly mortality, to the more upstream impacts on the left. So the social inequities that lead to institutional inequities, that lead to the living conditions, that really are the important drivers of what happens downstream in risk behaviors, disease and injury, and mortality. When we think about healthcare traditionally and healthcare services, we're mostly talking about the mortality and disease and injury areas, sometimes also the risk behaviors. I think there's increasing focus in those areas. But understanding that driving those things are the living conditions like the community institutions, the schools, that reflect the institutional and social inequities in our system, these are the real factors that affect us all and affect families here in the Commonwealth and everywhere. Then finally, the green box at the top of the slide I think is helpful in helping think about what are the actions that are available at each stage of this health inequity pathway. So again, at the downstream, we talk about filling the need for addressing health-related social needs. And a great example of this is what's happening through the Flexible Services Program in the MassHealth ACO context, where there's really a focus on thinking about housing instability and the need for to address food insecurity issues falling into that category. In the increased risk arena, here there are strategies that can help us mitigate the impact that focus on living conditions, and even further upstream, we're really talking at the base here about major social policy decisions that are not just made here in the Commonwealth, but that are influenced by our national choices. Okay.
So, is it fair if I try to give you an example here? So, for something like food insecurity, on the furthest downstream would be maybe connecting a patient with a local food pantry. Kind of in the middle condition and living conditions would say, okay, are there food deserts in communities that are not access to kind of fresh and healthy foods? And then probably furthest would be what are our policies around sugar in sodas and tax rates on certain types of things.
And also potentially zoning regulations. Where are the community dollars going in terms of bringing investment into the community? Are municipal leaders thinking about access to grocery stores, that sorts of thing? Okay. So, one more piece of context here. So I just want to highlight that the HBC is not brand new in thinking about these issues and in this space. In addition to the focus that we've brought to this through our cost trends report, I wanted to mention a few other ways that we're touching this space already. We've invested in addressing social determinants and advancing health equity through a variety of ways, and I think some of these things are just about doing our work, but doing it in a way that's asking questions differently. We're asking some new questions. So So not just thinking about when we look at the impacts of our investment programs, not just thinking about maybe averages across populations, but what's the breakdown into different population groups. So this comes through in our work in our research domains, in our evaluation programs, and even in our certification standards where we're asking ACOs, what are your habits and practices around stratifying and looking at your health outcomes across different subpopulations. Sometimes this comes through in supporting specific initiatives, as we have at the HPC, that are targeted at populations with likely greater social needs. So I'll mention our community hospital investment program chart, which really focused on complex patients, many times whose underlying drivers of increased use of acute care was social needs, as well as our SHIP care program, which we'll be talking more about today. And we've also worked to shine a spotlight on this issue, highlighting promising work and promising partnerships between the healthcare system and communities, notably through our learning and dissemination work in the form of an event we had last spring focused on these partnerships and best practices in addressing these needed clinical social linkages. But there's clearly a lot more to do across these different sectors at the state level, in our community-based social service sector, and of course in the healthcare system. And so through this work and in the lead up to defining the new project that I'm introducing today, we and our state agency partners spoke with stakeholders in the healthcare systems. We talked to community organizations and tried to capture a range of perspectives on this issue. And really, I think through that stakeholder work and our own internal reflection came away with sort of some of the understandings that are reflected on this slide. So in terms of context and focusing on the healthcare system for a moment, it's clear that ACOs and health systems broadly have some interest here, both clinical and financial, in addressing the social determinants of health. There are, I guess another way to say it is I think there are mutually beneficial opportunities here. It's a complex issue whether for every health system trying to tackle social determinants yields clear short-term financial benefits. So I don't want to gloss over that or oversimplify that concept. But I think in general there is an increasing need to look at this issue and unpack it and focus on thinking about over the long term where are the win-win opportunities, where are the mutually beneficial opportunities for ACOs to see improvements in the outcomes and costs related to their patient populations, and for communities as a whole to benefit from the standpoint of population health and overall well-being. And all this work has to be done in partnership. There's really no way, at least not that I'm aware of thinking about addressing these issues that doesn't involve quite a large array of partners. So we are certainly talking about healthcare providers and community-based organizations. We're probably also talking about additional institutions and stakeholders like state government for sure, local and community government, philanthropy, other kinds of organizations that exist in the community that are important players. And yet these partnerships are hard. And so the challenges here that exist, and a lot of these came out of our stakeholder conversations, is that there are a variety of challenges in just overcoming the barriers and the sort of silos in which these different actors are currently working. There are challenges related to culture, communication, data sharing, and legal issues to think through. So there are a variety of reasons why it has been challenging for healthcare and social service and other groups to work together to address these issues. Finally, in terms of the opportunity here, we recognize at the state level as well that there's a real chance for us to support the development of new collaborations and new frameworks for working together across different sectors as well as different kind of programs and policies. So, things like the efforts that communities are making through the community health needs assessment and planning processes, community benefits programs, which some nonprofit hospitals and HMOs undertake, as you know, and it's overseen by the Attorney General's office, population health management programs that are
activities that might be led by local municipal authorities, and CPH determination of need, community-based health initiatives. There's a lot of activity that is related to or directly, trying to address some of this work. And what we hear in talking with community groups and healthcare providers is that often these efforts are not coordinated or could be better coordinated than they are today and better leveraged to tackle these challenging problems. It's also worth noting that healthcare systems are often major anchor institutions in their communities from an economic perspective. And that's another sort of element or stream here that could be all tied in and better coordinated with this work. So as anchor institutions, these systems may be thinking about investing in communities, strengthening communities as employers in those areas, and with an interest in making sure that the overall community is strong. And through, I think, these anchor institution strategies, the healthcare system is sort of already recognizing that they have an important role to play in being drivers of improved social and economic conditions where they exist. And I will just note this map is not highly scientific. It's not meant to show only places where there are important provider groups, or it's really just not to GIS HBC standard. It is really just an illustrative graphic to try to highlight this general point. All right, one more context slide, and then we'll get to the punchline here. Finally, commissioners, as you know, we have been discussing now for a couple of years some funding that we have set aside and earmarked for some sort of technical assistance program for our certified ACOs. We have really held off from going full into this arena, given the really significant investment coming through the MassHealth program and the district dollars, and understanding that ACOs have access to and are benefiting from a variety of technical assistance through those initiatives. We have been holding off in deciding exactly how to allocate these resources. But we do have them, and we see an opportunity here to use these resources to further serve this goal of driving upstream. So, recognizing all of that context and those opportunities, the HBC and our sister agencies, including, as I said, the Office of the Attorney General, the Department of Public Health, the MassHealth program, and with the overarching support of the Executive Office of Health and Human Services, we have scoped out a new program that we're calling Moving Massachusetts Upstream, or MassUp for short. Our vision is better health, lower costs, and reduced health inequities across communities and populations in Massachusetts through effective partnerships between government, healthcare systems, and communities to address the social determinants of health. Our intention is to engage in policy alignment activities and to make investments to support collaborations between the healthcare system and community actors to more effectively address the upstream causes of poor health outcomes and health inequity. MassUp is sort of conceptualized or could be broken down into 4 major strategies. The first is an HBC investment program. This would be a new competitive grant opportunity for 2 community collaborations to work together to align their social determinants of health-related activities. And I'm going to go into a little bit more detail on each of these, so I'll just start with the broad overview. That's our investment program piece. Along with that investment program would come some technical assistance, more in that traditional TA concept for those investment awardees. This would be provided through the Department of Public Health and leveraging really the wonderful expertise they have in promoting local public health activities to address health inequity and these kinds of community-based collaborations. Thirdly, an evaluation that would seek to highlight what we
finally, a work stream that we're calling aligning policy, where we as state agencies would be working together to identify opportunities and, to the extent feasible, alleviate state-level policy barriers to successful collaborations, and thereby enabling more effective action at the local level to address social determinants. Some of these might be identified just through our internal work. Others might come out of the experiences that we've gleaned from the investment program. But this is, sometimes I think we talk about aligning policy in a light way. I would say we're quite serious here about trying to surface and understand across our different state agencies. And I'll just note that even in the Attorney General's recent guidelines on community benefits, I think that's a great example of the leading edge of this work, where those community benefits guidelines really try to tie in EHS health priorities and the DPH priorities as well, and try to speak with a common voice across state government on this topic, which is really our ultimate goal here. All right, so to talk a little bit more about the investment program, what we're trying to do on this slide is unpack the idea here of what would these investments actually fund, what would the new community collaboratives actually do. And there's still a lot of work to be done to flesh out the details here and fully define the expectations, but broadly this is the vision for what would occur. The first category would be in the kind of planning and coalition building activities. What we would see here is that a health system, or in partnership with a certified ACO, would convene a partnership with other actors in the community, such as municipal public health departments and community-based organizations. There would be an expectation around governance to make sure that all of the players at the table have an opportunity to thoroughly engage and play a role in the direction of the work. And we're working with this concept of engaging a trusted broker. We use different terms sometimes to define a neutral convener, a trusted broker organization. But the idea here is that in order to more effectively bring together these disparate voices, it would be helpful to have a neutral or financially neutral organization that could serve as a bit of a facilitator and mediator who understands the local community, may have some experience working across sectors, and would be able to sort of help guide the work that's happening across these partnerships. So having convened that partnership and chosen a trusted organization, we would be looking for the partnership to identify a structural barrier to health that they want to address. So perhaps transportation, housing issues, food insecurity, etc. And work with that neutral or trusted organization and their partners to develop a multi-level plan that would focus on not just the downstream effects, but also some of the upstream implications. Through the grant program and the funding available, this collaboration or partnership would develop strategies and approaches to engaging the community, thinking about information technology, data collection and sharing, staffing. We would look for the awardees to dedicate at least one full-time equivalent staff person to manage the effort across the partnership. We would be asking and expecting that there would be funds flow mechanisms established between the awardee institution and their partners. There would be execution on the multi-level plan, obviously, as well as then an evaluation overall. So I think one of the important things to understand about what we're thinking about with these investments is we're not looking to fund the provision of services primarily. So this is not a grant where we would be looking to make sure, for example, that individuals with food insecurity are given access to a local food pantry or expanding capacity in that way. That could be one of the strategies that's identified by the collaborative, but what we're trying to accomplish that's new and different and apart from the those more targeted sorts of investments is helping these organizations establish the infrastructure, the architecture for working together, and to think more in partnership with one another about how to align the work that may already be going on at these various levels, but is currently siloed.
And I would just jump in and give you a second to catch your breath there too, Catherine. I think this is a really important part of how we're thinking about this program, because we could use these investment dollars to hire case managers to then be able to connect these patients to services and actually pay for those additional services. And then the grant money would run out, and there would not be a sustainable model for continuing those services. And so, as Catherine said, here we're really kind of thinking about investing in a structure that we think would be, and would hopefully design that would be sustainable, after these dollars run out, and that also could be replicated in other communities and be able to take those learnings. So it is a different way of thinking about this investment, and I would say to the commissioners and certainly with our interagency partners, we're still scoping this out a little bit, and I think, as Catherine will say, we want to kind of spend a good chunk of this year talking to communities and providers and really trying to be a little bit more articulate in exactly what we expect, what the dollars would go for, so that when we get applications that we're going to get some really exciting proposals. So just wanted to kind of underline at that point. And one thing, another important point and aspect here is really around the evaluation, and really being able to understand what works and document that, and make sure that we're, again, able to take that and to be able to show the results to other institutions and communities and be able to do this. We don't want this just to be a one-time pilot that goes nowhere. That's not necessarily our goal. And I would reflect on this point, again, I was at a research conference earlier this week. There is so much tremendous energy nationally around addressing social determinants of health. And one of the interesting themes that came through from this meeting was some anxiety among researchers that there's a lot of disparate projects going on. People aren't necessarily thinking about evaluation in a robust way at the beginning, and a concern that if we don't really think about that up front, we could spend a lot of money 3 years from now, and then we say, oh, nothing worked, and we're on to the next health policy topic. And that there is actually a responsibility for organizations that are doing work on social determinants of health to really think about evaluation, so that we're making the case in the future about what is the return on investment, what is the business case, why does this matter, why is this important, how does this impact the health of populations, so that we're not in a position later on where, like many other hot policy topics, we say, okay, well, we tried that and that didn't work. This is an opportunity to try something and show that it can work. And so I think we take that responsibility seriously as we think about this program and designing this program, that we are contributing to a national evidence base.
Kathleen, thank you. That was a great presentation. I'm excited about the potential. A couple of thoughts. One is that coalitions that come together to do these kinds of projects succeed or fail in some part because not enough attention has been given to the process of keeping the coalition together. The work of maintaining the group is equally as important and requires, I would suggest, almost full-time attention from very skilled people who know how to do that. I think about a project in Boston several years ago where there was a cross-city effort to decrease the number of shootings involved gang members. Some of you may remember that project. It was very creatively put together, brought in the police department, the public health department, social service agencies, and over the course of, I think it was 18 months, as this project was held together,
got national attention, and deservedly so. I don't quite have the information as to what happened that it unraveled, but it did. And when a project is that successful, the thought that it unraveled is just painful. And so the caution would be that as you frame the proposal and as you look at applicants, that you look for the effort to really nurture the process as well as having the process nurture a policy change.
One thing I would actually just say in response to that is, as we think about both this initiative but also the MassHealth's work around flexible services, I think you underscored one of our primary objectives, which is really to forge relationships and partnerships with entities that have not historically been engaged. And I think that, yes, it's important that we as state agencies continue to meet and gather and think about these things. But perhaps even more importantly is the relationships and engagement that we can forge through this work. And even if the outcome is you have a large medical system thinking about the other social service needs of their patient panel that they may not have thought about, or not known to go to a certain housing authority, or not thought to contact department of transitional assistance for certain things. I think just those forging those relationships is top of mind as we think about a lot of this work.
I know you're not done, but I'll offer a couple comments. I feel like the kid on Christmas Eve looking at a big package, and I'm really excited about this. This is work I've been doing for a long time, and I think, and have, David's heard me complain about the lack of alignment between the DON dollars, the community benefits, and just general work in the community. So I am thrilled that we're finally seeing these as three pots of resources that can come together for to really reflect community change. So I just love this. Just a couple of comments. I think to Barbara's point, I think there's having a strong backbone organization is really important here, because you have to keep this the momentum going. And a lot has been written about the collective impact model. Those folks are here in Boston. I think there's some lessons to be learned from looking at that. I also appreciate the fact the health equity focus here. I mean, you phrased it as inequity, but I think concentrating on what are some of the things that are clear barriers to people accessing both health and social services and having good health outcomes is important. And I love the evaluation piece here, because there are disincentives already built into these systems that don't lead to good information sharing, good coordination of care. So I think having that evaluation as an opportunity to identify those disincentives for future policy change, I think is important. I would just pick up on something Lauren said, which is I think there's an opportunity here not just to look at the social determinants such as housing, unemployment, transportation, but to look at patient populations, particularly those high utilizers of care, either emergency room care or rehospitalizations, whose social needs add to those ER visits or those hospitalizations, because I think that really gets at the populations we're trying to improve care for, and then gets at our other agenda items of reducing the cost of care. So, great work.
Great. Well, thank you very much for those comments and for the support for this work. I think we'll be moving forward in thinking through this investment design, and I'll come back to our next steps in just a moment. I will breeze through the next few slides, but I do want to touch a little bit on the policy alignment workstream. This is a neat slide that we've tried to put together really just to reflect the various streams of work that are happening through different state agencies right now, and to visualize a little bit where these initiatives fall within this sort of upstream downstream trajectory, and then the idea being that MassUp is looking to bring some of these efforts together into better alignment. And on the aligning state policy workstream, we are, as a group of sister agencies, committed to thinking about mitigation strategies to address policy, regulatory, or legal barriers that both that we may know something about now and that may be identified through our investment program to align guidance where we can, and to think about how we as a state could better develop policy and programming to further this work in general. So we've been talking about engaging both state agencies and stakeholders in helping steer this work. And not yet formed, but the concept here is that we would try to create a steering committee that would include state agencies and be advised by some community stakeholder organization. Not sure yet if this would be a brand new group or whether we might be able to leverage one of the many stakeholder bodies that already exist and advise state agencies on these topics. But that's the broad focus here and vision for state level policy change consistent with MassUp. And finally, a timeline that looks at these two work streams side by side. So we're moving forward even now on trying to put some of the pieces in place for the investment program. This will include working with DPA to provide some resources to support their efforts in this space, including the provision of the technical assistance and this very important evaluation work, which we've all agreed is critical. So we're working on that now. Over the course of the summer and early fall, we are planning to undertake and offer a number of opportunities to engage stakeholders. We have done some of this work already, but we'll be trying to do more and really using it to help us refine the concept here and really test this idea that we have that a lot can be achieved if we focus on this better alignment and creating these new partnerships. So as we start to put together the investment program design, I think we're really going to need and benefit a lot from hearing from stakeholders. And here, I certainly don't just mean the healthcare provider community. Based nonprofit community organizations that are doing work, and potentially backbone organizations or these kinds of groups that could act as trusted brokers as well, so that we really make sure this concept is solid. And hopefully before the end of the calendar year, we will be issuing the investment program as a request for responses, and certainly would be then moving forward toward a procurement process and awarding contracts as early as next spring.
And I know it's early, but how many are you anticipating? What's the length of the cycle?
We're talking about funding 2 awards, so 2 collaboratives in different communities over the course of 3 years. And on the policy alignment work stream, we are kicking off those conversations now, and we'll be leveraging some of the stakeholder engagement work I just mentioned, also to inform the policy agenda that we might want to be focused on. And we are talking about our first order of business being collectively DPH, HBC, MassHealth, AGO, and with significant financial support from the AGO's office to plan a learning forum that is sort of under the aegis of the Community Benefits Program, but would be designed to be a first opportunity to speak both from the state perspective and to hear from providers and community organizations about their experience and how we can all better forward to talking a lot more about it in the future. Next item on our agenda, and I'll invite Vivian Jaime to the table. Vivian is our senior manager on our team. Vivian's going to give us an update. As you know, commissioners, we have a relationship with an organization called MassChallenge HealthTech to support innovations in the space of digital health, and this is a collaboration that has been new and exciting for us over the past year, and Vivian is going to highlight where we've been and some of the things we've accomplished, and I'll turn it over to her.
Okay, thank you, Catherine. So good morning, almost afternoon, commissioners. So excited to share a little bit of an update on our collaboration with MassChallenge HealthTech. For those of you that aren't as familiar, MassChallenge HealthTech, formerly known as Pulse, is a digital health accelerator here in Massachusetts and the Commonwealth's official digital health hub. MassChallenge HealthTech was founded in 2016 with the support of the governor, the city of Boston, and the Massachusetts eHealth Institute, among others. MassChallenge HealthTech is a private-public partnership with the goal of making Massachusetts a leading digital health hub nationally and globally. And the HPC's goal in entering this collaboration was really to promote provider access to digital health innovations and to identify solutions that address areas of high priority to the HPC. So our collaboration with MassChallenge is threefold. First, we serve as a champion in their core program, which means that we issue challenge areas or areas of high priority to the HPC, and then MassChallenge actually sourced startups that were working on those high priority areas. After a rigorous vetting and matchmaking process, we did partner with 3 startups and supported them as a dedicated advisor. And so we have been working with those startups from January through May is when the program runs, and I'll be providing an update later on how that collaboration went. The second component of our collaboration with MassChallenge is really focused on promoting partnerships with community-based providers, which we do by offering a scholarship through MassChallenge HealthTech for startups to pilot their solutions with community-based providers, and also through events. And I'll talk about an event that we held in collaboration with them back in November. And then the third component here is a research collaboration with the goal of better understanding the current barriers to adoption of digital health solutions and how we might address those barriers. To date, we did have some stakeholder interviews and we held 3 focus groups, so today I'll be able to share some of the findings from those focus groups. So first, I just wanted to highlight this event that we held back in November. In order to promote linkages between startups and different types of provider systems across the Commonwealth, the HPC co-hosted this Health Check ACOs event back in November in partnership with MassChallenge HealthTech, MeHi, and the Brigham Innovation Hub. Our very own Catherine Harrison provided some information about the landscape of Massachusetts ACOs based on what we know from our ACO certification program and the capabilities that ACOs are developing to succeed in value-based payment arrangements. She also provided some information about the MassHealth ACO program and some opportunities that came out of that. Then Lauren Stuntz, the director of MeHi, moderated a panel with speakers from Partners, Community Care Cooperative, and One Startup, 3Germ. The event was very well attended and it led to a great conversation about different types of provider systems, their varying needs, and how startups might understand ACO's incentives and tailor their pitches accordingly. I'll next talk about our participation as a champion in MassChallenge HealthTech's core program. So back in September, the HPC issued 5 challenge areas for startups, which were aligned with our policy priorities. As you can see, the first few are around reducing avoidable acute care utilization, and the last 2 are aligned with our Shift Care Challenge investment program, which one of which was to address health-related social needs, and the other one to provide timely access to behavioral health care. And so, as I mentioned, after a very extensive judging process by experts that know startups very well and a matchmaking process through which we heard pitches from 18 different startups. We ended up extending offers to 3 startups and worked with them over the course of the last 5 months. So I'll talk about each of them and tell you a little bit about what we've accomplished together. So first, MOAT is a symptom checker that helps triage patients to appropriate care settings. So it's very much aligned with our goal of reducing avoidable ED utilization and with the goals of the Employer Coalition. So over the course of the last months, they did meet with some of the members and partners of the Massachusetts Employer Health Coalition, including the Group Insurance Commission and South Shore Health. They've also shared some data with us and met with, or will be meeting with our research and cost trends team about patients who were successfully diverted from the ED. So who had expressed the intention that they were going to go to the ED, then they went through the process of the symptom checker, and as a result ended up seeking care in a more appropriate setting. Next I'll talk about Dynamic Care Health and Marigold Health. Both of these really support patients with behavioral health needs. Dynamic Care Health is a digital platform that supports patients with substance use recovery through a suite of services, including monitoring use of different substances, rewarding patients for having successful negative tests, and also providing recovery coaching through their app. And then Marigold Health is a text message-based group psychotherapy for patients either with substance use disorder or mental health conditions. Both are really promising and unique approaches to a similar problem. We did host an event, a webinar at which both Dynamic Care Health and Marigold Health presented their solutions to HPC awardees and other providers, and that the recording of that webinar is available online if anyone wants to learn more about these 2 startups. Both of them were also recipients of the scholarship that we offer through the MassChallenge HealthTech program, and it provided $25,000 so they could pilot their solution with a community-based provider. Dynamic Care Health will be piloting their initiative with Leahy Health, and Leahy has actually also committed some in-kind funds, and Harvard Pilgrim Healthcare has also added some funds to that. So now we'll be able to do a 50-patient pilot over the course of 4 months in the setting in the Danvers and Gloucester locations. And then Marigold Health also leveraged their HPC scholarship to actually develop the Spanish version of their app, and they will be piloting that with Behavioral Health Network in the fall. So we're really excited about these 3 collaborations and had a very positive experience working with the startups. I'll now turn to just telling you a little bit about our research collaboration with MassChallenge HealthTech. The goal of this is really to learn both what's working well as well as some of the barriers to adoption of digital health solutions and how we might overcome some of those barriers. So as I mentioned, to date, MassChallenge did hold a few stakeholder interviews, and then we also held 3 focus groups. One was with startups, the other one with providers that have in-house innovation teams, and the third with providers that do not have dedicated innovation teams. And I'll talk a little bit about the findings from these. The next phase of this work will be to do a survey to get a broader sample of startups and providers to tell us about really what their needs are and how we might be able to support them, and then to create an actual resource, whether that be in the form of an innovation guide or some other resource that might help promote these linkages between providers and digital health solutions. So just wanted to highlight a few of the findings from the focus groups. First we really wanted to learn about what does a culture of innovation at a health system look like, and what are some of the operational activities that are leading to successful collaborations. And so what we learned is, as far as a culture of innovation, engagement from leadership from the get-go is critical, and also understanding the alignment between digital health solutions and the organization's mission, including promoting access to care, improving care, and lowering costs. We also heard a lot in every focus group about the importance of strong provider champions who really, are folks that have enthusiasm, credibility among their peers, and a willingness to test things out and learn and explore. I want to take us to the quotation that really gets at, something that systems have found is working. Breaking through the silos is key. If you can commit to a process by which people from all the relevant departments can sit together and review the solutions, creating that process is important. And so what we really heard from both startups and provider systems that are able to enter successful collaborations is that really, getting somebody from leadership, management, from the IT department, from an innovation team if you have one, getting everybody in the room from the get-go to really learn about these solutions and surface some of the issues that might come up and see how they might address them. That getting that group together from the very beginning is very effective, rather than having multiple conversations and not really surfacing all of the possible challenges that can come up at once. And lastly, I'll just mention the importance of including the patient perspective. This really was emphasized by a lot of the providers, either in the form of doing focus groups when you're launching a new pilot, or doing patient interviews and really finding ways to get that patient voice and understand what is working for them and what isn't. And lastly, I'll just talk about some of the barriers and possible solutions that were surfaced in these focus groups. So really, I think both providers and startups emphasized the lack of resources, particularly in IT, as a barrier to adoption of solutions. And then as far as solutions, I will bring us to the quote, "Fee for service is killing us right now and disincentivizing providers from using a product like ours that provides better care at a lower cost." And so really the startups were sort of asking, we need to move to value-based care more quickly in order for our solutions to really make sense for these businesses. And so we are, I will say, separately from this work, we are in the process of working with Bailiff Health Purchasing to do some interviews and put together a policy brief to understand why has having APM adoption stalled in Massachusetts, and to try to sort of move forward on this. But that's pretty much it for findings. I'll pause for any questions.
What's our relationship going forward with MassChallenge?
So this was a one-year commitment, and so we have an opportunity to renew the commitment and to continue the relationship and to be a champion for another cohort. I think we have interested in feedback from commissioners. I think we are inclined to do another year and to keep the relationship going. I think we've learned a lot. MassTech HealthChallenge has learned a lot from us, and so I think it has been a mutually beneficial relationship. And I think one of the things we learned and understood, and Vivian said this really nicely, is, and I think we want to be a little bit more proactive in thinking about this, is where are there specific challenge areas that health plans, providers, and the HPC that we can identify, maybe all of us wanting to say, let's put in one challenge together, like the Leahy Harvard Pilgrim HPC opportunity that came together more organically, but maybe there's an opportunity proactively to say, hey, if we're all going to be champions, let's be champions together, because then we can really leverage the resources and have a bigger impact. So that's one of, I think, a key lesson learned from our first year of engagement.
There's a comment in terms of digital health solutions may lack interoperability. That is a staggering stop in all discussions, and I wonder what next step thinkings need to occur in order to address that from that kind of discussion.
Yeah, I mean, I think, some have certainly developed workarounds where where interoperability is challenging just because of, the EHR system that the provider system is operating with. So there are some workarounds, but it is an important issue that we need to think about how we can address.
Certainly one that's beyond the scope of any individual startup to tackle, but ripe for innovation from all sides, I would say.
Great, thank you.
Thank you.
So I am going to invite Griffin Jones, who is interim policy director for the strategic investment team, and some folks from his team to join the conversation. The next couple of agenda items focus on some evaluation update from our recent investment programs, and then without further ado, we will welcome and look forward to hearing from our invited guests from Holyoke.
Great, thank you very much, Catherine. As my colleague, Dr. Jessica Lang, the Senior Manager for Care Delivery Evaluation, comes up to join me here, let me say that I'm pleased to speak with commissioners here at an inflection point for the Strategic Investments of the Health Policy Commission. Of course, it's summer and it finally feels like it, so I know what's on everyone's mind is what has the HPC invested in terms of care delivery innovations. And so I am happy to be here on the precipice of our last two agenda items here. First, for Dr. Lang to walk us through some previews of our evaluations coming up here of our programs, and then finally to get to some of the stuff we enjoyed most, which is just getting out of the way and letting our awardees speak directly to you about their experience. So second only to that is our work evaluating what it is that they have done for the Commonwealth and for their patients. I'm pleased after the conversation about MassUp that I certainly don't need to underline the importance of evaluation and telling these stories. So without further ado, let me turn it over to Dr. Lang to talk about our work.
Thank you, Griffin. So I'm here today to provide an update on our evaluation process and to share a few highlights that hopefully will whet your appetite for the reports that we're developing. We evaluate all of our investment programs in order to understand and document how they were implemented, what impact they achieved, and to what extent the model is sustainable. David mentioned the importance of planning evaluation at the outset, and we do plan evaluation as part of the design of our investment programs, and we collect data throughout implementation. Typically, there's a lag time following the close of a program before we have complete data, and for some programs and data types, that lag is longer than others. So right now, we're working on the analysis and report development for both CHART Phase 2 and the HCII programs. So I will briefly preview some emerging findings for both CHART and HCII evaluations, but wanted to mention that for Shift Care, data collection is up and running, and you will be hearing from one of the awardees in a bit. So to refresh, CHART Phase 2 funded 25 programs at 27 community hospitals and lasted for 2 years. The goals of this investment program were to orient organizations towards value-based care, to utilize data and analytics to better serve patients, to integrate care across medical, social, and behavioral health needs, and to provide care in the most appropriate community setting. So it's important to note that the CHART program was intended to impact both patients and the community hospitals themselves. So naturally, this is a complex program to evaluate, especially since the 25 hospitals each designed and implemented a distinct care model, and they adapted their approach continuously throughout the program. So we approached this evaluation through a combination of both quantitative and qualitative methods and data sources. Our intention is to derive maximum insight about what was accomplished and how and why. So our goal now is to produce a concise and clear evaluation report that captures the accomplishments of the cohort of community hospitals. The first part will be a narrative documenting key aspects of the CHART program, including the unique collaboration of the hospitals with the HPC during implementation planning. We'll illustrate how hospitals designed and implemented their programs and how they spent their award dollars. Now, the second part is the findings from our mixed methods analysis of the program's impact. We're considering impact broadly in keeping with the transformative goals of the CHART program. The quantitative aspect of program impact is acute care utilization, which includes readmissions and ED revisits. We're analyzing utilization using case mix data provided by GIA. final batch of data has just become available this month, and the analysis will be complete later this summer. Throughout the program, we also collected extensive qualitative data that we used to assess other aspects of hospital transformation, including community partnerships and the integration of behavioral health and health-related social needs. So it's worth noting that the standard we're using for evaluation is chart-driven change relative to the hospital's starting point. We don't expect that all hospitals will land in the same place in all of these capabilities at the end because they didn't start all in the same place. So we will speak qualitatively to the impact of the program on hospitals. Now today, I'll share some of what we've learned about the impact on patients who are served by the CHART program. So first, I'll describe the eligibility criteria chosen by the hospitals and then the perception of the patients themselves. So as I mentioned, the narrative part of the report will describe the collaborative implementation planning process. The HPC worked with hospitals for roughly a year as they collected and analyzed their own data. So hospitals were guided to assess the needs of their patients and to decide what criteria to use to define a target population for their initiative. Based on statewide trends, the HPC urged hospitals to pay particular attention to patterns of high utilization and behavioral health, but we didn't require that all hospitals adopt one standard set of eligibility criteria. But this triangle figure captures the variability in the eligibility criteria that hospitals selected. In the center pink triangle is the hospitals that chose history of high utilization as the criteria for their target population. On the left, in the blue trapezoid, is the hospitals that chose behavioral health diagnosis as their criteria. So you can see that high utilization and behavioral health diagnosis were the most common criteria, but many hospitals used a combination of the two, and several included criteria related to medical or social complexity. As you heard during the MassUp presentation, addressing health-related social needs was a component of a lot of CHART programs, either by design or because it emerged as an important area as they got to know their patients. So unlike some traditional programs that targeted readmissions, none of the CHART programs used exclusively medical criteria. And that put the CHART hospitals in a new frontier of population health. So the patient mix varied. The CHART hospitals across the board were serving patients with complex needs. We believe that including the patient's voice in this evaluation is critical, and so we collaborated with a team led by Chris Lewis at the BU School of Public Health. Their team interviewed 51 CHART patients, all of whom had a history of high utilization or behavioral health diagnosis. When they described their experiences typically interacting with the healthcare system, they mentioned experiencing stigma, having multiple providers who weren't all on the same page with each other, feeling a lot of confusion, and ultimately feeling that healthcare was something that happened to them. So this confirmed that using these various eligibility criteria, the hospitals were reaching patients whose needs were not being met in the healthcare system. When patients were asked about their experiences, what they really valued the most about the CHART program consistently was the relationship-based approach. They were typically assigned to a member of a CHART team who reached out to them, and they valued really appreciated a caring person who connected with them, who made themselves available. It was especially important to them that they could call a CHART team member about anything instead of having a different person to call about different types of needs that might come up for them. So hearing patients describe their experience this way really validates the CHART team's emphasis on CHWs and other patient-facing staff who would connect with patients in their homes or their communities. Ultimately, patients did feel that the CHART teams had changed the way they interact with healthcare. In sharp contrast to the disempowerment that they've experienced a lot of, they felt more confident and knowledgeable and more actively engaged in their own care. They noticed and appreciated more communication among their multiple providers. In the end, a lot of them said that they felt less reliant on the hospital, especially the ED, to access the care that they needed. So we'll discuss these findings in more detail in the report that we expect to release into this year. Any questions or comments about CHART evaluation before I move on?
I noticed one of the factors was changes in utilization. Will we have any cost data also related to that?
We don't have cost data. we can infer cost savings from reduced utilization, but we don't have the full picture. So moving on to the HCII investment program, I'll share some highlights from the three pathways: TCCI, telemedicine pilots, and the neonatal absence syndrome programs. Four telemedicine pilots all successfully provided behavioral health care through telemedicine to people who otherwise had substantial barriers to accessing BH care. All four had high levels of patient satisfaction, and some documented additional accomplishments specific to their target population. Haywood provided in-school psychotherapy and personalized referral to community services for students and their families. Now, this was in a community where there's a real lack of local outpatient BH providers. So for these students, having therapy during their school day avoided having to miss school and avoided their parents having to take off work and drive a long distance to a provider. PPOC provided BH assessments to kids in a primary care setting, substantially reducing the time that they had to wait for this service. Riverside provided therapy to older adults in their homes. They expected some challenges in using the technology with older people, but possibly because they did a really good job in their design, they found that most patients were comfortable right away, and then those who weren't initially did grow more comfortable by the end of the pilot. UMass used telemedicine to expand the reach of their SUD treatment program to an additional campus, and they saw a decrease in readmissions for the enrolled patients. So taken together, these pilots demonstrate the feasibility of deploying tele-BH in both clinical and non-clinical settings. It's particularly noteworthy that we have two non-clinical settings. Providing care outside of traditional medical settings has its own added complexity. So we'll describe the outcomes and some lessons learned, complementary to the tele-BH implementation guide in this report, and that will be next on deck after the chart evaluation report. Yes?
Just a quick question on the Riverside Community Group. Do you happen to know the average age of the older adult?
Sure. I not specifically, but I can tell you they did actually have a lot of people who were in the sort of younger seniors. So it was not typically the oldest adults. They did find that there was more comfort and more past experience with using this technology than they had originally expected. But for the targeted cost challenge initiatives, these 10 awards used a wide variety of approaches to their challenge areas that included behavioral health, social determinants of health, and end-of-life care. One of the 10 is still in progress, but most are done, and they're wrapping up data collection this summer. So on this slide, there's just a few highlights. Several programs have reported reduced utilization in the form of ED visits or readmissions, and we're seeing some other important outcomes as well, such as increased preventive care and increased housing stability. Quite a few programs face challenges in quantifying and tracking health-related social needs. And those issues and the strategies they developed is one thing we'll discuss in the evaluation report. To complement these quantitative outcomes, we again heard from the patients themselves as well as program staff. We collaborated with a team led by Palmira Santos at Brandeis for a study we call Resonance and Relevance in Care Coordination. This study is a deep dive into the goals and priorities of patients with the most complex and challenging circumstances and the mostly unreimbursed work of documenting and responding to those goals. We chose 4 TCCI programs that serve very high-need populations, including 2 that are focused on housing instability. The Brandeis team talked with patients about their experiences and with staff about the challenges and strategies and the adaptations that arose in their programs. And so those insights will also be incorporated into the TCCI report. These charts from the NAS program may look familiar from the excellent presentation given by Munish Gupta at the last meeting of this committee. Munish leads the NeoQuick statewide quality collaborative that we worked with to gather data on the 6 NAS programs. These hospitals all deployed non-pharmacological approaches to caring for opioid-exposed infants, and that included breastfeeding, skin-to-skin comforting, and rooming in with parents. Based on data from year 1 of the program, which served over 1,200 mother-baby pairs, they've had a remarkable impact in reducing the need for pharmacological treatment of the baby's NAS symptoms. So avoiding the need for medication medication has allowed more babies to avoid the NICU and to go home sooner. Since the NICU is a very costly site of care, this has the potential for substantial cost savings in addition to the obvious clinical and human benefits to the babies and families. We'll be receiving the final round of data for the 2-year programs at the end of the summer and working with NeoPIC on some additional analysis. And we'll also be incorporating results from our partners on the outpatient side of this work from BSAS, who are focusing on the support for mothers during pregnancy and during the postpartum months. So to recap where we are in time for those 3 pathways, the telemedicine pilots have wrapped up their implementation, and the TCCI and NAS programs are near the close of implementation. We'll have a separate report for each of the 3 pathways coming out over the next 12 months. These reports will include the exciting successes that I've just described, and also the lessons learned. These programs all innovated and pushed the frontiers of care delivery, and so naturally it was not all unicorns and rainbows. And where we did observe some instances where program implementation didn't go entirely smoothly or didn't get all the results that were hoped for, that's also really valuable knowledge that we're excited to share, especially with potential future implementers. Ultimately, we hope that these evaluations will serve the goal of evidence-driven care delivery transformation by telling the story of these programs.
I think it's also worth noting that at least with the MAS program, it has the potential to be the new standard of care.
Yes.
And the group utilizing that and doing that should take great pride in that.
I would just add, I know how difficult this is because when you make multiple grants to multiple organizations, all in generally the same area, but all doing things very differently, it never rolls up the way you want it to. So I appreciate what goes into this, and I think the initial findings and are great. Look forward to the actual written reports, and I appreciate, and Griffin and I talked about this earlier, not only the highlights but the lowlights as well, because I think we also learned a lot from what doesn't go well. So very good.
Thank you, Commissioner. That comment is really well taken, because it has been a challenge, and to roll this up and to tell a story and a narrative across, in the case of CHART, 25 different awards, different communities, different starting points, and yet we're going to make it happen, and we'll I think have a lot of really important lessons to be shared. And I do want to just highlight, while at the HPC we have a dedicated evaluation team, they work very closely with our kind of learning and dissemination activities. We do think about those things slightly differently with slightly different goals, but nonetheless we have a priority that if we're seeing good trends, if we're seeing good things here, we want to try to get that information out as quickly as possible, understanding that a rigorous evaluation can take a little bit longer. So that's why we've tried to do things like the Tele-BH Guide and other different types of resources and webinars and convenings and other activities, so that we're not waiting necessarily the full 12 or 18 months after the program is done to be able to start to make that change and impact to other communities. So I just want to highlight and thank you, Commissioners. You've always been very supportive of making sure that we make those investments in all of these different activities around the investment programs.
We save the best for last.
Indeed, Commissioner. So let me introduce Adrian Anderson, or reintroduce our Manager for Behavioral Health, overseeing our Shift Care 2D investments, and then as our awardees take the stage here, just to give us a quick reminder of where we are in terms of the launch of the Shift Care Awards, and what we can look forward to and look at the Holyoke Medical Center team's accomplishments thus far.
Thank you, Griffin, and Commissioners. So in a few moments, you'll hear from John Kowalczyk and Maria Quinn, who represent the Holyoke Medical Center Shift Care 2B Award with the HPC. Excuse me. To provide some background information, I'll quickly review the cohort in which they're participating. So Shift Care is a new $10 million investment that focuses on community-based, innovative
projects designed to reduce avoidable acute care utilization. 6 of the awards are focused on addressing health-related social needs, and 9 are focused on providing medication for addiction treatment in the ED. This care model, which I won't get into the graphic here very much today because I'll save it to articulate more specifically HMC's awards care model in a few moments. But the care model is inspired by a care model piloted at Yale New Haven Hospital a few years ago, published because it's clinically effective and cost effective as well. And we've built upon it a requirement for deliberate, purposeful, and really collaborative partnerships with community-based outpatient behavioral health providers and other types of creative partnerships as well that vary across the awards, and you'll hear a bit more from HMC about that. And here's a list of the 9 hospitals in this cohort. As you can see, they're distributed throughout the Commonwealth. We have HMC, of course, selected here, representing Western Massachusetts. And you can also see that each award in the cohort contributes generously to the success of Shift Care overall through in-kind contributions. A status update on the Shift Care program is, you can see the orange section where we are now. All 15 of the Shift Care awards have launched at this time, and for the 9 hospitals in the cohort who are initiating medication for addiction treatment through the ED, the HPC has contracted with a team from Brandeis University to provide both learning collaborative facilitation and external evaluation, which we're really looking forward to. We're in the process right now of collecting baseline period data right now, so stay tuned for data to come at a later meeting. So I will now introduce specifically the team from HMC. So here at a high level, we have a description of their program, starting with target population, adult patients who present to the emergency department at Holyoke Medical Center following an opioid overdose or who screen positive for an OUD at the time of their presentation. Their primary aim is to reduce emergency department visits by 20% as compared to baseline over the implementation period of 18 months. That's the implementation period for all 9 of the hospitals per Brandeis cohort-wide evaluation. And the partners for the HMC award, I'm going to talk a little bit about it during HMC's presentation, are Andara Center, which is providing training and staffing for peer recovery coaches in the ED, especially during evening hours, as well as River Valley Counseling Center, providing outpatient mental health services, Providence Behavioral Health Hospital, and the Holyoke County Sheriff's Department, and those creative partnerships I mentioned, sort of enriching the scope of this care model. And so I won't get into the service model itself too much. I don't want to duplicate anything. You can see here some of the variety of staff roles in the model, and overall that it follows the same structure as the original Yale model, identifying eligible patients at the ED, and then using social workers, psychiatric advanced nurses to connect those patients to care, especially long-term outpatient follow-up. All right. So with that, I will turn it over to John and Maria to further introduce themselves. I'll bring them this clicker, and they'll share more about their program.
Afternoon, thank you for having us. Is this thing on?
You may need to get real close to it, John. We're into you.
Usually the continuity is my problem. So if you can't hear me, just let me know, please. So thank you very much for having us. Thank you to the lead for having us here today at the HBC. So Maria Quinn, my colleague, and I represent the Holyoke Medical Center and the Valley Health System, which is our collaborative of 4 other organizations that we'll talk about in a minute. So my name is John Kowalczyk, and according to the screen, I'm the Shift Care Investment Director, which is something I had a similar role in our
So if our affiliations can better.
Yeah.
So I'll talk about the medical center in a bit, but the Holyoke PBMA essentially been around since 1905, so long track record there. Comprehensive home health services, people come into the homes who are specialized in nursing, as well as PT and physical therapy and OT. We also have a hospice element to that organization as well. Also under the group, our physicians group, which is the Holyoke Medical Group, is a hub for our ACO. It is a place in which we also have, we'll talk about later, community health workers located there to help connect folks who are leaving ED, who are already in our patient group, and connect them with services through the shift plan. So it's sort of a hub as well. It's primarily adult services. However, there are pediatrics and OBGYN services as well. The River Valley Counseling Center is really kind of a behavioral health hub. While we have it in the hospital, this is a more community-based organization. There's two clinics, full-service clinics, one in Chicopee, one in Holyoke. We do have integrated care in the school systems, so we provide clinics integrated in both Chicopee and Holyoke communities. And it is it also does HIV and AIDS programming as well as public assistance program. Of note, back to the Holyoke Medical Group, we are a patient-centered medical home, so importance and HBC service involved in that process. Twice again. Excellent. So the communities we serve, we are in the Western Mass area, as previously noted. There are people and services beyond Worcester, Western Worcester, so folks know this part of the state. We won't talk about Berkshires or Franklin. They are wonderful counties, but we don't serve them primarily. So the other two counties we do have a presence in are Hampden County and Hampshire County. In particular, the three major cities that we manage and deal with patients are Holyoke, Chicopee, and West Springfield, all located in the Hampden County area. Hampshire County, we serve 5 communities. This is not going well, is it? Is it better now? All right. South Hadley, Belchertown, Southampton, East Hampton are some of those communities. Roughly 180,000 folks were in a service area, and approximately 89% of those live in urban areas. So roughly that is our demographics that we manage on a regular basis. I think this is an important slide. Much talk has been made about social determinants of health. I think this graph sort of speaks to that. I'll have some other data points to talk about as well. But essentially, of the 40,000 or so folks who live in the city of Holyoke, about 53% identify themselves as Hispanic/Latino. This is a very diverse community. It's also a very poor community, as you can see. In Holyoke alone, about 28% of the population lives at or below the federal poverty line, which is roughly about double the national average at this point. The non-Spanish speaking is prevalent, obviously. About 46% of the population speak language other than English. About 40% of that is Spanish speaking. Just to give a general sense of social determinants and some of the issues we're dealing with, the median household income is about $39,000, a little below that, while as in the rest of the state, we're looking at about $77,000 of median income, and at the U.S. level, probably about $62,000, depending on what stats you're looking at. Hampden County also is a high prevalence of diabetes, probably the top in terms of Hampden County. It's #1 of all the counties in the state. Hampden County is also first in adult smoking, large occurrences of obesity, about 28% of the population is obese. It is second only to Suffolk County in major crimes, homicides and other crimes. Home ownership is only about 41% in Holyoke itself. The rest of Hampden County and the areas nationwide, as well as Massachusetts, are more at 60% or higher in terms of home ownership. Homelessness is an issue. About 6,000 folks were touched in the last year or so, according to our Transit Housing Authority, who help to provide services to those folks. So in Hampton County alone, and that is an underrepresentation. That issue, obviously, it's hard to determine who is, serving on a couch and living elsewhere, and these are folks really just touched by the services in that area. Just so you know, the Holyoke Medical Center is the largest employer in the city, and we employ folks mostly out of Holyoke itself. About 300 plus employees live actually in the city itself, so we're very connected and integrated with the community of Holyoke. Next is our from the Center for Health Information Analysis. Closer. This gives you a sense of how where we discharge folks to. The 47% or so of our population comes right out of Holyoke and discharged back into the community, followed by Holyoke and followed by South Hadley and Chicopee, Granby. So we are very connected to our community, and that's where they go back to wherever they leave us. I think this is an important slide as well. Our connection to the community is very important to us. With this, but money where our mouth is in many ways, where about $18 million last year was spent in indirect or direct costs from the hospital into the community. This takes, next slide we'll talk about where that investment comes from. So roughly about $67 million, a little more than that, since 2014, contributed back to our community through the services, in-kind services that we offer back. This is how we deliver some of those services. There are about 8,000 or so hours of volunteers hours that we contribute to the community. Some of these are actual volunteers that work and greet patients at the door. Others are our employees who work in the community to give back. Transportation is obviously an issue with the property levels we have within the community. So we try to go out and get our patients and bring them to us. About 3,000 rides a year are delivered, a month are delivered by our valet services and our shuttle program. We do have a dedicated van for our partial program and behavioral health. This is a population that certainly has troubles with navigating the public transportation routes. Feeding our population is a big deal for us. We take that seriously. We provide free community meals at least twice a month. Maybe more coming for that. Support groups, educational classes. As you can see, many of these things are targeting what we feel are the social determinants of health. Diabetes management, parenting classes, nutrition, a number of other things that may come up. Community health workers doing outreach, getting to folks in their homes, trying to educate them, folks who have transportation issues. These are all services often that are free to the community, but pay dividends in terms of the overall health for the folks we serve. Next slide. This is our mission. Our marketing department will be angry that I did not put the entire mission on there, so I just used the top line. So we won't tell them. It's lovely, but it's a little long. Essentially, what is missing here is important. They talk about how we deliver this mission, and honesty, dignity, respect for the patients are on top of that. Expert care, really partnering with the community is really underlying theme as well. It's right in our mission statement, and really trying to make a difference in all those we touch. But it was a little worried, so I figured I would just give you a brief extension. The next is our hospital. This is in 1892. Of course, the buggy. We've had advanced since then. Of course, the Mass does have motorized vehicles. You know that. But it started off as a 40-bed hospital, and we have grown and advanced since then. We're now at about 198 beds. We serve we have about 1,300 employees. It's actually more than that at this point. About 7,500 patients are admitted, and about 45,000 visits each year go through the ED. So it's a busy location. Doing a chart grant, HBC insurance offers a brick and mortar costs about $2 million. So we do have a newly within that is a dedicated behavioral health wing, which is sort of a real prize there. So this is this is a rendition. So that EED actually does exist. So $2 million was spent on that. So I just want to make sure we didn't spend, that you know, we didn't spend $2 million only on a crash. Next slide. So according to, again, our friends at the Center for Health Information Analysis, this is from their profile. Essentially, we are considered a mid-sized community high payer hospital. Depending on who classifies us, we are also a disproportionate share hospital and a state general hospital. Public payer mix is about 76%. That's among the highest in the state. We have really trended towards, which is I think, a trend throughout the system, towards moving towards outpatient visits. We've dramatically increased those visits. As in this fiscal year, we had about 123,000 or so, 24,000 outpatient visits. The last line really speaks about readmission rates. That is obviously a priority, not only with the ACOs and with the HBC in this grant, but for our organization. And I really think it speaks to meeting our patients where they're at in the community and trying to do quality work at a cost-effective way. So it's really been a focus of trying to do this kind of work to meet the needs of our consumers. To that end, we are always striving to look at how to make things standardized and systemic in our approaches. As of last year, we were the first hospital in the state, certainly in Western Mass, to achieve the ISO 9001 certification, which really is a quality management system that kind of reflects our commitment to quality, transparency, and customer service. So we're proud of this, and we just raised the flag, I guess, I think last week we did this. This really comes from the manufacturing world. I can talk more about it later, but it is a standard that we're happy to achieve and we'll continue to strive to continue this. Our efforts have led us an A with Leapfrog as a safety grade in terms of analysis of where we at compared to other hospitals in the state and the country. So we're very proud of that, and so I think I put that next slide. So getting to the kind of reasons why we respond to this, excuse me, really is a unique opportunity for us to kind of stem as a nationwide epidemic. It's obviously priority for HBC and the governor's office. It dovetails nicely with our previous work with the CHART grant, which bolstered our behavioral health resources, reduce recidivism. I think it really goes hand in hand with that. It's helping, I think, to meet some of our needs in the community. So we felt this was a great opportunity to kind of extend what we're already doing with the CHART grant. So I will speak a little bit about the ED. This is an actual picture of the ED, so it does exist. Just note that for the record. It just opened in 2017. It does have a designated behavioral health area that we're very proud of. It was designed by really the consumers. We worked with a lot of advocacy groups to design the color schemes, the shape of the windows, and everything else down to the details. So we hope it's patient friendly. Again, some of the reasons why we pursued this grant, we have been making a concerted effort to develop MAT services now in the clinic that's operationalized. It was at the time just kind of getting off the ground when we applied for this grant. We thought this was a great way to continue that efforts. At Holyoke Medical Center, I think from previous initiatives and continue today, we're very proud of the robust case management services we provide. It's really meeting the clients where they're at. It's doing a lot of patient navigation, care coordination. Innovative technology is something our leadership is very concerned about, wants to be, even though we may not be a large institution, wants to be part of how we do data informed care in our patient population. Obviously, consideration for social determinants of health. Part of this grant is something that the agency has been working on. Obviously, through meeting the patients and getting to our health, we identify this area as a big concern. So this, I think, helped in line with some of the things we've already been doing. Good stewardship. If you're a small independent hospital in Western Massachusetts, you better be doing it right, and good quality as well as at a reasonable cost. So it's always been something cases, we deal with this devastating impacts on kids. Our staff deal with it, some of our staff members deal with it, families deal with it. So this is something we thought was important to us. So we felt that made the connection to our mission. These are just some quick stats underscoring the importance of this grant and why we're doing it. Essentially, 6% higher substance use or cigarette visit than most of the state. About 3 times the number of visits in the state that come into our hospital for substance use. And we had over 6,000 EMS incidents in 2016 alone, just in Chipley and Holyoke, in terms of folks responding to opiates. And many of these stats are really underscore what's really happening here. These are folks who, in many ways, are touched by our services. There are many more who are not. And I think the SHIP grant allows the opportunity to reach out to the community, link with services, and to really sort of move folks from maybe pre-contemplation to contemplation around those stages of change. Utilize some of those skills we've learned from working with this population. So at this point, I'm going to hand it over to Maria Quinn to give you more details of the services that are here. And this will be fine.
Thank you. My kids would tell you I don't need this microphone. So my name is Maria Quinn. I'm a psychiatric nurse practitioner at Holyoke Medical Center, and I'm also the program manager for the SHIP Care Grant, which we are actually calling Bridging to Recovery. So I think it's important to highlight that. We wanted a name not just something that said shift, which means something to us, but within the organization. But also I think it focuses on the solution instead of the problem. So before getting into the actual intervention and what we're doing, it's important to talk about how we prepared our team and how we got to where we are today. So initially it started with weekly meetings between just John and I, kind of strategizing who needs to be involved in this, who do we need to bring on board, who's already on board, and how do we best utilize our current resources. And it has since grown to include directors from multiple departments, case management, directors from the emergency department, IT, patient navigation, our outpatient MAT clinic, community mental health workers, and data as well. So it's really fantastic the fact that folks have committed coming to this meeting once a week, every Wednesday. We missed it today, we were excused. Wednesday at 9 a.m. and really coming together to figure out how to make this work. And that's really something to highlight, is that it was something where people were trying to figure out how to make it work, not, well, because of this isn't going to happen. It was really, let's figure out how to get this happening for us. Meeting with the emergency department, leadership and providers, this was huge. This is where our initiative is taking place. So this is somewhere we had to really work to get buy-in. And that started with working with the director of nursing down there. Right now, the ED is in between leadership. So our emergency room providers are through a contracted agency called NES. So the chief of the ED actually resigned a while ago, so right now we're in between providers, but the interim chief is somebody who's been with Holyoke for a long time. So what I did was first started meeting with Kelly, who was the chief, the nursing director. Then she got me meetings with the head of NES as well as our interim provider, and really kind of talking about what this grant is, how we're looking to really help out, because ultimately everybody is thinking, oh my God, what another thing I'm going to have to do, something else I'm going to have to chart on, and really kind of me bringing to them, no, we are looking to have this be more of a resource for you. And then from there, helping them understand that, then going to the monthly meetings with the emergency department providers, all of them being on their agenda every month talking about it. And I think it's really important to highlight that when we first started this, we had one provider that had the X waiver, which is the waiver you need to provide buprenorphine, and since then we now have 11 providers that have gotten their waiver, which is, I think, pretty fantastic. Also, kind of including everybody in the emergency room, so not just nursing and providers, the techs, security. It's actually really interesting. They've referred clients to us as well. So meeting with our community partners, early on we identified that we wanted Gandara to be there because they were there during the CHART grant. I wasn't there during the CHART grant, but we had peer recovery coaches in our emergency room and it went really well. They were well received, so this was a really easy sell. And then River Valley Counseling Center as well, who is the behavioral health provider in our area. We also engaged a consultant. I think it was important to recognize that we don't have all the answers, we don't have all the skill sets within our organization, so bringing somebody in from the outside to really build up our team and provide clinical supervision and trainings was really important. And then finally we had a kickoff meeting, which Molly actually came to, where we had all of the team members, all of the various departments. It was about 2.5 hours long. We had leadership, senior leadership from Holyoke Medical Center. Everybody there presented, our community partners as well. I did a presentation on addiction, understanding what addiction is, kind of like the biology behind it. Then each department did their own. Our consultant did a piece on building health equity, understanding social determinants of health. And then finally we had a client who had engaged with peer recovery coaches through the CHART grant and talked about his experience in meeting a peer recovery coach in the emergency department and how that really changed the trajectory of his life. I mean, he was really going down a really dark path and continues to be engaged in care, got his children back, is in treatment. So it was a really, really successful meeting. And then also the goal of that meeting was to let them know that we'd be meeting periodically to review how things are going, not just at the end. Because it's important to know that what you're doing is working. All right, so how we identified who our intended demographic is we used the diagnosis codes that Brandeis provided to us. And then with that, within our own electronic medical record, we created a flag for those folks so that when they came to the emergency room, something popped up on the screen that would, I think says like SHFT, so that internally we would see that and we would see as somebody that would be a potential candidate for shift. So this is kind of some of our very, very early data. So it's important to understand though too that we realized once we were looking through all of this that people were not being, it's just an underestimate. Not everybody was getting an opioid use disorder diagnosis as appropriate. So I'm looking through charts, people that clearly were there for opioid use disorder were not getting it, so this is underreported. So between January and February, we had about 100 ED visits each month with these individuals with opioid use diagnosis. Almost all but one had a behavioral health diagnosis. I just think it wasn't entered in there, so I would say almost 100%. More than 45% are Hispanic. So it really lines up with what John was showing before. And then of these visits, 30% were there because of an overdose. And about 25% came back within 30 days. So this is why we're doing what we're doing, right? This graphic I absolutely love. This is what we distributed during our kickoff. This was truly teamwork. I had wanted something to kind of distribute internally to all of everybody at Holyoke Medical Center to understand what we're doing. Because if you send emails, you talk about it, everybody forgets, they read it, they go shuffle, but I wanted something like printed that we could just kind of have hang it up, you're sitting down at your desk, you look up at this. So we went through it, this is really like a roadmap of our intervention and all of the different players and how we're doing it and why we're doing it. And currently it's on the screensaver for the hospital, so it comes up on the screen, and it's also in our weekly or bi-weekly newsletters as well. So this is the actual work. So what we're doing is we're increasing social work presence in the ED. We already have a big social work department, but we have a champion, so to speak, who we have placed in the ED. In the middle of our emergency department, it's like this glass kind of bubble where there's computers and things. So he's there, and he's more visibly accessible. So kind of like that visual cue of, oh, Ryan is here and he's scanning charts, but also it's that kind of constant talking with providers within the emergency department. The peer recovery coaches and the we have the peer recovery coaches that come to the ED 8 p.m. to midnight, and they're going to be there 7 days a week, which is pretty fantastic. And again, since they were there for the chart grant, they were already known to the emergency department staff, and we've trained them on how to complete the shift, what we call the shift assessment within our EMR. Narcan is a big one as well. We're looking to actually give Narcan. A big chunk of our budget was to actually purchase and provide Narcan to clients or family members identified at risk. So initiating Suboxone in the ED, I talked about the number of providers with the waiver. You know, you have to really kind of like keep that fire going, because it's like they got the waiver, but people get nervous about it. So I provided them all with an algorithm on exactly how to prescribe, like based on this COW scale, you start here. If they're not, then you go. It's an algorithm that was through the National Institute of Drug Abuse, so it was already out there. I laminated it, made it pretty, and they're using it, which is really, really helpful. And referring to treatment. So one of the things is we have a bridge clinic, which I'll talk a little bit about, but knowing that if they start somebody, they just tell them the next day, show up between 10 and 12 upstairs at our clinic on the 4th floor, and then we will continue their treatment there. Addiction consults on the med floor, that's me. So I do, when I first came to Holyoke Medical, there was really, we do awesome work, but there was not really a lot of attention on addiction, and that's not a diss on the hospital. I think it's important to recognize where you have deficits, because otherwise you're just going to kind of stay neutral. So for me, it was like, what the heck are we doing? I cannot believe that we're not doing anything about this. So I started to really work with providers. I started to get do the addiction consults on the floor, starting people on buprenorphine or methadone on the med floor to reduce, you know, AMA discharges, get people treated, reduce readmissions, and now we're actually in process of it's been approved, but we're doing all the final touches on getting a protocol so that other providers, and not just me, are starting folks on buprenorphine and treating opiate withdrawal. Okay, so outside of the emergency department, we have the call center. They call everybody who comes through, so this is an opportunity. You know, we're not going to catch every single person. We're not there 24 hours a day in terms of coverage for the shift grant. So this is an opportunity to catch those folks. We have a nurse navigator who's our newest hire, but she's really that person, like I said, there to fill the gap. So if people are, if we find that they are, that they qualify for the program, but they decline, she's this person to kind of figure out, you know, what's possibly holding that back. And then we have community mental health workers that are in all the primary care offices, and we've actually gotten some referrals from there as well, where they've just walked folks over to the emergency department who showed up and said they wanted some treatment. So beyond the ED, this is another picture of our ED. The collaborations with the community partners, like I talked about with Mandata and River Valley. Team members, they're going to be tracking how individuals are doing outside of the emergency department. So once if we initiate treatment within the ED or refer to treatment, they will be followed up on, so whether it's with our social work individual or through our recovery coaches or community mental health worker or nurse navigator. But it's been really important to say, like, don't be tripping over each other. We don't want 5 people calling the same person over and over again. So it's really kind of delineated roles is important. Okay, and then like I said, we've created a flag, so anytime somebody does come back, we get flagged again to know that they're there. So this is kind of our marketing for our own MAT clinic, the Comprehensive Care Center. It's located in the hospital on the 4th floor. We have 2 providers. I'm one of them, and then our other provider also, she's an infectious disease specialist, so she treats HIV, Hep C, everything else there. do Suboxone, Sublocade, and Vivitrol. The open access hours are really, really big in terms of getting our population treated, and it's been really helpful, and not only from the ED, but people are coming from the community, so we'll see how long we can sustain that, but so far it's working well. It's a nurse-driven program, bilingual clinical staff, which is important given our demographic. We have a partnership with River Valley Counseling Center where we meet weekly to talk about all of our clients. They're involved in that. They also expedite all of our referrals so that when somebody comes into treatment, they get them into therapy quicker. And a couple days a week, they come there and do on-site therapy, for folks who are a little harder to catch, to get them to go to multiple appointments. And then this is the Gandara Center is where we're working with our peer recovery coaches, where they're placed in the emergency room, and then Hope for Holyoke is a peer recovery support center right in Holyoke that is really, really fantastic, and they have been exceptional and just provide a lot of support. They come to the hospital if I need them to, so if I have somebody on the med floor and I'm like, they might benefit from meeting like a peer coach, they'll send them up to meet with somebody on the medical floor. They're pretty great agency. So then this brings us to the goals. I think culture change within our entire organization, just even talking about addiction, like I had said before, and really kind of looking at the things that make us uncomfortable are really, really important to move things forward. Let's see, reducing the number of emergency department visits, like we said, the A&M hospital discharges related to substance use and withdrawal, increasing access to recovery-oriented services. So while we know that this funding is looking at initiating MAT for people that are eligible in the emergency department, it's also really important to understand that medication is not for everybody, and there's multiple paths to recovery, and really looking at every individual as an individual and assessing where they are and assessing what will work for them. And then finally, providing the Narcan. That's it. Thank you so much.
Maria, you said 100% of those that you identified had a health diagnosis. I'm wondering about a co-occurring mental health SUD.
That's exactly what it was. So everybody that on that was somebody with an opioid use disorder diagnosis, and then.
Have you had any trouble getting the folks into the mental health side of therapy?
I wouldn't say trouble in terms of getting access to. I would say trouble in terms of keeping them engaged.
And I'm just also interested in any workforce issues that you've identified in doing this. Difficulty recruiting social work staff.
No, because we used a lot of folks that were already within the hospital. We did hire the newest hire that she's just coming on board is the nurse navigator. But we were really lucky in that we have, really like a great infrastructure already, and just we're leveraging the folks that we have there.
Great presentation.
Thanks for your time.
John, Maria, thank you so much for driving out here and giving this presentation. I just want to say, thank you for taking on this work. Certainly, when we design these grant programs, we always have a moment where we wonder if anyone will apply and really embrace the work. And it's just so incredibly validating to see how closely this work aligns with the values of the organization and building off some of the experience of CHART. And we all know from the HBC side how much work goes into even thinking about applying for a grant, and then we announced these awards almost a year ago, and they're most of the programs are just now launching, and the tremendous amount of work that goes from learning that you got the grant to then actually starting to see patients and collect data. And so I always say, it feels like we've done all of this work and we're just getting started on the work, but all of this pre-work that you detailed is just so incredibly important for the success. And I think you really gave me and I think all of us an appreciation with this specific work about how much of it is really breaking down silos between within the hospital, outside of the hospital, and also just identifying all of those gaps where patients may fall through. And I think that is just really critically important for the goals that we're trying to accomplish here about engaging people in treatment, engaging families, and how much work and consistent work that takes, both from engaging those patients, but also keeping the entire clinical staff and organization every day thinking about that and committed to doing that. And Maria, it sounds like you are a big part of making sure that everyone is focused. I love that the graph of the street, that's being prominently displayed within the organization. I think is just tremendous. And so we're just so excited for these grants to go forward, and especially Holyoke Medical Center in such a challenging and high-need community, John, as you helpfully articulated. And just a real credit to both of you for the work that you're doing, and to Spiros and to the leadership at Holyoke Medical Center for making this such a commitment in terms of the engagement to the community. So we are excited to learn from you. As you saw from that cohort, commissioners, it's a diverse cohort of hospitals. We have urban hospitals, we have rural hospitals, community hospitals, big academic medical centers, and I think in particular, given the demographics and the challenges in your community, we're going to learn some really unique things from this award. So I just wanted to say thank you.
If there's no other business, I think